Good evening, everyone, and welcome to tonight's session on treatment. My name is Kirsten Pilati, the CEO of Breast Cancer Network Australia. Before we begin tonight's activities, I would like to pay my respects to the traditional owners of the land on which we meet here tonight in Melbourne, Wurundjeri land, on land of the Kulin Nation. And I pay my respects to the elders past, present, and pay tribute to those emerging leaders who are very much a part of our network and helping us to make sure that we can really work to reducing the gap that currently exists for breast cancer people all around Australia for First Nations. Tonight is an action-packed night and we have so much to get through with plenty of interactions between you. I really want to encourage people to send through your questions. This is such a special moment to be able to be with some of our leading clinicians from around Australia. But there are many breakout groups and activities we'll be doing, so I'll give you some instructions around that. But first, who is Breast Cancer Network Australia? We know that there are many people tonight joining us for the very first time. So our role and purpose as an organisation is to make sure that we can provide all Australians with the very best treatment, care and support. And we do that by a number of ways, by providing information and support just like tonight. And that includes our helpline that is there with our member services team who can take any questions and help you to navigate into the local services or information and support and care in your local area. But we also provide opportunities to connect, and tonight will be a special way for you to connect in some of the smaller rooms. And we're looking forward to some of the conferences we'll be holding hopefully later around Australia this year. And our voice. We really do make sure that we can represent the needs of all of those affected by breast cancer, whether they be women diagnosed, men, people who identify as culturally and linguistically diverse, or other marginalised groups in Australia. It's our job to make sure that we represent you wherever decisions are being made around breast cancer care. And we certainly have seen some major breakthroughs because of the power of our network. That network is more than 150,000 people, most of you who have been diagnosed with breast cancer. I'd also really like to welcome tonight those partners of people who've been diagnosed. And thank you. You are a really important support network for those people diagnosed. This year, more than 20,000 women will be told they have breast cancer and 164 men. BCNA will make sure we're there for them, but also for everyone who is living well after a breast cancer diagnosis. And that's certainly what we want to help you be there for. So as I said, tonight is action-packed. There is lots of presentations happening by some of Australia's leading clinicians. There'll be poll questions that really are asking you to interact with us so we can see where we're at. We're going to have 4 breakout rooms a little later to enable you to really get to much more specific and ask many more specific information questions and help you, as I said, connect with each other. And I really want to encourage you to send through questions throughout the night. Don't leave it to the end when you might forget about what that question is. The instructions for this evening will come up on the screen, and if there are any problems, please put them into the question section or call Redback and we will support you through it. I do want to acknowledge Cancer Australia, who have been long-time supporters of Breast Cancer Network Australia, and tonight their support is in allowing us to deliver this information. They often translate really good clinical information into information and support for health professionals, but also for consumers. And so I would really encourage you to look at their statements, which look at aiming at providing evidence-based informed decisions for cancer care to make sure that you understand your rights as a consumer after a breast cancer diagnosis. So before we get underway, there is one woman who has been with us since we began in 1998. She is known and loved right around Australia. She's one of our ambassadors, our board member, and one of Australia's living treasures. So please welcome Raylene Boyle.
Hi, I'm Raylene Boyle from Breast Cancer Network Australia. I've been a board member there for a number of years now, in fact, right from the start. We're going to look at some very important subjects tonight. We're going to look at current treatments for breast cancer, both early and metastatic disease. And we're going to also look at the role that the GP plays in treatment and care. What the future with breast cancer looks like, and we all hope, of course, it's going to be looking a lot better than it has been and is today. In my day, when I was diagnosed 25 years ago, there was little help. The drugs were very different to now. And really, basically, you were told to get on with your life. There was little care, little looking after, little instruction as to how to move forward. It was just get the treatment done and go back to your life, which of course didn't happen because your life changed forever. I hope you take good info away from tonight's program, ask questions and build connections and enjoy. This is about us, and we want you to learn a lot more about your disease and grow very good connections. So enjoy.
Raylene is such an important person in our network, and it was great to hear from her tonight. We're going to take a short break, and after that, we're going to hear from 2 oncologists, but we're going to separate you into 2 groups. You'll get that instruction through. So both of those speakers, Dr. Belinda Kiley and Dr. Michelle White, will introduce themselves, and I want to thank them ahead of their presentations for their time tonight. So grab a cup of tea, get ready to move into your separate groups and enjoy the next session on treatment.
Good evening. My name is Michelle White. I'm a medical oncologist and I work at Monash Health in Melbourne and also at Cabrini Health. And it's my absolute pleasure tonight to present to you on the treatment options for patients diagnosed with metastatic breast cancer. I'd firstly like to thank BCNA for asking me to be involved in this exciting event. Just to give you some information of how this session will work, I plan to talk for about 35 to 40 minutes. And at the end of that time, we'll then address questions. We would encourage you to send through your questions at the time they come up, and we will review them and then discuss them at the end of my session. As Kirsten has said, we'd really like this to be an interactive evening. And so in that setting, we thought we might start with a couple of surveys. So we'll look at the first question on our survey, which is, would you consider participation in a clinical trial to possibly gain access to a new treatment? So this is certainly an important question that many patients would come and discuss with me. And I'm hoping that patients have had an opportunity to discuss new and exciting treatments that might be coming through. So if you can start the poll now, that would be fantastic. We'll just give it a couple more seconds for everyone to have an opportunity to put through their ideas. And my plan would be that at the end of the presentation, we'll actually go through the results of the survey. Fantastic. All right. We might now move on to the second polling question, which was to ask everyone, has your oncologist ever discussed participation in a clinical trial with you? We know that there's increasing number of trials available for patients diagnosed with metastatic breast cancer. So polling is open for this now too. Many oncologists hopefully would have discussed this issue with patients, but obviously we were interested just to get an idea if this is something that you have had an opportunity to discuss with your oncologist. Obviously, sometimes their patients may not be suitable for clinical trials, and we'll discuss some of those issues during my presentation tonight. Okay, we might close the voting there and get on and move on with the talk. So as I said, my topic is treatment for metastatic breast cancer. So just to set the background, we know that a diagnosis of stage 4 cancer is devastating for all patients diagnosed. However, in an exciting development, there's been a lot of new treatment options that have become available in the last 10 to 15 years. And what we certainly appreciate in 2021, that management of a patient diagnosed with metastatic breast cancer takes a whole village, if you like. There needs to be a number of clinicians involved in their care. And this list is certainly not exhaustive, but these are the sort of people that come to mind when I imagine a multidisciplinary team looking after a patient with metastatic disease. So often patients would have clearly a medical oncologist, a radiation oncologist, certainly a palliative care doctor may well be involved in their treatment. More and more frequently these days, patients may have a surgeon involved in their care, even in a metastatic setting, whether it be a breast specialist who might have to operate on the primary if it's still in situ or present, or a neurosurgeon if a patient has brain metastases that might need surgical intervention. Clearly, the general practitioner is an absolute pivotal part of the breast cancer team, and many patients will go and see their GP to bounce ideas off them after discussions with other members of their treating team. And then clearly members of the allied health team that are involved. Again, this isn't an exhaustive list, but psychologists, exercise physiologists and physiotherapists, and most importantly, and certainly a critical component of the team, is the breast care nurse, and we'll discuss their role a bit later. In 2021, we understand that metastatic breast cancer is a very broad term, and the treatment is really determined by what subtype of breast cancer the patient has. In the past, we really had a philosophy of one size fits all in terms of treatment options, but we now have a far more sophisticated understanding that we need to target special features of each individual patient's cancer. And I'm hoping in the next 10 to 15 years, we're really entering an era of what we like to call personalised oncology, really treating the cancer of that individual woman or man. So how do we know what subtype of breast cancer a patient has? Certainly the information comes from a biopsy, as I'll discuss in a minute, but the vast majority of patients diagnosed with stage 4 breast cancer have hormone-positive, HER2-negative breast cancer. So about 70% of patients will have this subtype of breast cancer. In the upper left corner, you can see hormone-positive and HER2-positive breast cancer is a fairly uncommon diagnosis. There's a slight typo in the bottom left square, I apologise for. That should say hormone-negative, HER2-positive breast cancer. That comprises about 12% of all patients diagnosed with breast cancer. And triple-negative breast cancer, again, a similar percentage of about 12%. Part of the reason it's really important to know what subtype of breast cancer a patient has is that treatments that work for one subtype may be completely ineffective for other subtypes of breast cancer. So this is really critical information for us to have. The way we gather this information is through biopsy, and we would generally prefer to get a biopsy of a site of metastasis or a secondary deposit when a patient relapses with breast cancer. And the real reason for that is that we understand that in about 10 to 15% of cases, the biology of the breast cancer can change from the original primary to the time when a woman's diagnosed with metastatic breast cancer. The image on the left shows a breast cancer cell that has the 3 potential receptors or gates found on a breast cancer cell surface. And basically, a breast cancer cell can have all 3 of these, 2 of these, 1 of these, or none of these, as shown on the cell on the right, which is known as a triple-negative breast cancer. So the green gate on the left is the HER2-positive gate, which allows us to target with various treatments. The black gate is the estrogen receptor, and the orange gate is the progesterone receptor. And gaining information about all 3 of these is absolutely critical. I also wanted to mention de novo metastatic disease. So in about 10 or 15% of patients, when they present with their what is thought to be early stage breast cancer, scans identify metastatic disease, or at the time of diagnosis, the patient has stage 4 breast cancer. This means the patient's disease is incurable from the time of their diagnosis, which is obviously a devastating situation. But it's important for patients diagnosed with de novo metastatic disease to know that often their tumours are very sensitive to treatments, and they can often have very prolonged responses to the treatment, perhaps more than many patients who have relapsed after having had an early stage breast cancer. These patients often are included in clinical trials, often because they don't have issues that make them ineligible for clinical trials. So how do we treat breast cancer that is spread to different parts of the body? Breast cancer particularly likes spreading to certain organs within the body. It particularly likes spreading to the lungs, the liver, the bones, and you can't see it on this image on the right, but also to the brain. The important fact about the spread of breast cancer is that even though there might be involvement in liver or lungs or other organs, the cells themselves originated from the breast and they respond to breast cancer treatments. So sometimes patients are a bit perplexed when I'm talking about breast cancer treatments, even though the tumour cells are found in their liver or lungs. But it's important to treat where the primary has come from rather than where the spread has gone. The exception to this model is the brain, which is what we call a sanctuary site, meaning many of our treatments are not able to get up into brain metastases to be effective. And this applies to many chemotherapy and other targeted treatments that we use. So for many patients who have brain metastatic disease, we really have to focus on other treatment modalities, such as surgery and more commonly radiation therapy. And pleasingly, there's been huge developments in terms of radiation therapy to brain metastases with much more targeted or stereotactic radiation, now often our preferred treatment option rather than treating the whole brain itself. Pleasingly, in recent years, we have had a couple of new medications that do have activity for brain metastases, and we would certainly hope in the next few years that continues to be what we see. So how do we manage a patient when they're diagnosed with stage 4 breast cancer? Typically, oncologists will start with the most active treatment for that particular subtype of breast cancer. And usually these treatments have been identified in clinical trials where the new treatment is compared with the previous standard treatment and found to be better in terms of response. And so that becomes the new standard of care for patients. Over time, unfortunately, cancer can develop resistance to these treatments, or unfortunately, sometimes the cancer is resistant to treatment right from the start. And at that point in time, the tumour deposits will either start to grow or new sites of disease will be identified, and a change of treatment is needed to address the new activity. So you can imagine there's huge interest in trying to develop drugs that overcome resistance that might make all our treatments more effective for longer periods of time. Apologies. So now let's focus on the different treatment options for the different subtypes of breast cancer. And we'll start with the most common subtype, as I mentioned before, with about 70% of women having hormone receptor positive breast cancer. So for women who have hormone positive breast cancer, we have a large number of hormonal treatments that are very active against this subtype of breast cancer. There's some drugs that have been around for quite a long time now. Tamoxifen, as I say, an old drug but a good drug, and aromatase inhibitors, which have also been around now for quite a while. But there's been huge developments over the last 10 to 15 years, and some of these new drugs will include a group that I'll discuss in a minute known as the CDK4/6 inhibitors, a new medication known as fulvestrant, and the PI3 kinase inhibitors. The image on the right explains why we need to block this pathway for tumours that are estrogen receptor positive. So you can see the estrogen receptor, when the estrogen molecule enters it, is activated and sends signals into the cell to promote growth and division and resulting in the cancer progressing. So we have a reasonably long list of treatments that are effective for stage 4 hormone positive breast cancer. And again, this is not an exhaustive list, but I really just wanted to highlight we have lots of options, pleasingly. So the aromatase inhibitors such as anastrozole and letrozole can be used in combination with this new class of drugs called the CDK4/6 inhibitors. And these include drugs like ribociclib, whose other name is Kisqali, palbociclib, also known as Ibrance, or abemaciclib, also known as Venetio. The other drugs include fulvestrant plus ribociclib. So fulvestrant is actually an intramuscular anti-estrogen, so an injection in your bum like a penicillin shot. And then we have other options such as exemestane, which is another aromatase inhibitor, which can be given with one of these new classes of drugs, the everolimus, which is a PI3 kinase inhibitor. good old tamoxifen, and an aromatase inhibitor like exemestane can be given on its own. It's important to note that a number of these treatments, in particular aromatase inhibitors and fulvestrant, only work if a woman is postmenopausal. So for women who are premenopausal when they're diagnosed with metastatic disease, we need to pretty quickly make them postmenopausal for our most active treatments to be effective. And we can do this two ways. We can either inject a little pellet into the abdominal wall to basically turn off ovarian function. This is a drug called goserelin or Zoladex, and it needs to be given every single month. Or alternatively, a patient could have surgery to remove their ovaries before starting these other treatments. Now, we know that a woman going through a natural menopause has a very slow deterioration in her estrogen levels, and often her menopausal symptoms over that time tend not to be so severe. But if we take a young woman and immediately stop her ovaries, you can imagine that her menopausal symptoms are often quite profound, and they can have a very negative impact on her quality of life. So symptoms like hot flushes, mood changes, anxiety and depression, and vaginal dryness and lowered libido can have a really negative impact on the quality of life of a young woman. And it's certainly important that these issues are discussed with an oncologist, as we do have a number of treatment options that can help manage these complex symptoms. Likewise, for men diagnosed with metastatic breast cancer, they also need to be on a drug like goserelin or Zoladex to also further reduce their estrogen production, as well as those other treatments, as I mentioned previously. Chemotherapy does have a role for women diagnosed with metastatic hormone receptor positive breast cancer. However, it's not our usual first go-to therapy. And a lot of patients are quite surprised when I start talking about using hormonal therapy when they are diagnosed with stage 4 breast cancer, and they worry that they need a more aggressive approach like chemotherapy to really attack their cancer. But part of my job is to really educate patients that the best treatment for hormone-positive breast cancer that has metastasized is actually hormonal therapy, both in terms of its effectiveness and also in terms of the quality of life a patient might have on this treatment, and hopefully a very long, durable response to this treatment. So there are really two scenarios where, for a woman with metastatic breast cancer, I would look at using chemotherapy. The first is when I've exhausted all treatments, hormone-based treatments, and unfortunately this is certainly a circumstance that many women diagnosed with metastatic hormone-positive breast cancer will find themselves in. And the second situation is where there's very significant and rapid organ impairment. And the reason in that situation that I want to institute chemotherapy is that chemotherapy certainly has a faster onset of action. So if I'm concerned someone might be in liver failure, it's certainly a common situation where we'd start with chemotherapy and then move back to our hormonal therapies once we've gained disease control. Some of these new treatments that we mentioned include the CDK4/6 inhibitors, and essentially what they do is they work with the hormonal therapy to improve its effectiveness. So we've already mentioned that they're used commonly with anastrozole and letrozole for patients with metastatic breast cancer. These drugs, we now have 3 drugs in this class that are all available through the PBS, and it's a real credit to BCNA for its role in advocating for these drugs to be available to all patients as first-line treatment for metastatic hormone-positive breast cancer. And more recently, one of these drugs, ribociclib, can also be given in certain circumstances in later lines of treatment. I also mentioned fulvestrant. This is a drug, as I said, that is given intramuscularly, so like a penicillin shot. It's given once a month, and it has a different mechanism of action to the other types of hormone blockade. It also is available through the PBS, and again, BCNA had a huge role in allowing this drug to be available to all women through the PBS. And it can be given on its own, or it can be given in combination with one of those drugs, as I mentioned before, the CDK4/6 inhibitors. But there are lots of new exciting drugs coming through to treat metastatic ER-positive breast cancer. Drugs like alpelisib, which is like the everolimus tablet that I mentioned before. So this is another drug that is a PI3 kinase inhibitor that works hand in hand with hormonal therapy. This class of drugs can be a bit difficult to administer. They can have significant side effects. And certainly alpelisib in Australia is currently only available through clinical trials, but there are a number of clinical trials open. And if this is something that interests you, it's certainly worth discussing with your oncologist. There are other drugs like that fulvestrant drug that I mentioned before, but there's certainly focus on trying to develop oral preparations rather than having to have an injection in your bottom every month. And finally, there are also drugs that block a different receptor that I haven't mentioned to date, which is called the androgen receptor, which can also be found on breast cancer cells. Typically, these drugs are used to manage prostate cancer, but there's a number of clinical trials also looking at their role for metastatic hormone-positive breast cancer. Let's move forward now to triple-negative breast cancer. So as you remember from the small pink circle back on our original slide, patients who have triple-negative breast cancer don't carry any of the receptors that we typically are able to target for patients with metastatic disease. So up until recently, nearly all the treatment options available to a woman diagnosed with metastatic triple-negative disease are chemotherapy options. And for many women, they would be on chemotherapy for the rest of their life, which is a really challenging situation and is obviously associated with a lot of side effects. In recent years, there's been huge amounts of research at looking at other treatment options for women diagnosed with triple-negative breast cancer, and there's been a number of really exciting developments, particularly looking at new investigational agents like immunotherapy and PARP inhibitors, and we'll just cover them in a bit more detail. So immunotherapy is a really novel treatment that basically harnesses the body's own immune system to attack the cancer. And most of us are aware that it certainly has been shown to be a very active treatment for a number of other cancers, such as melanoma, and it has really changed the natural history of this illness, which in the past really didn't have many treatment options. And it is now available through the PBS for some other cancers, such as lung cancer. How do these treatments work? And they're really quite fascinating and really quite sophisticated in the way that they're able to work. So typically we would expect that our immune system would attack a cancer cell if it develops, because the cells do look different to our normal body cells. But what we know is that many tumours or cancers are able to immobilise our immune system so that they allow free growth of the cancer cells. What immunotherapy treatments do is they turn off this process so our immune system can identify the cancer cells as being foreign and try and attack them. It's really common for women diagnosed with stage 4 breast cancer to immediately want to be on immunotherapy. They've heard about it, other patients who've received this treatment. They've been on chat rooms for other patients diagnosed with cancer. But we do know that for some subtypes of breast cancer, immunotherapy is not an active treatment. We know that for patients with triple-negative breast cancer, that it certainly does have some activity, but to date, it's not been approved through the PBS in this setting. Many clinical trials are open and would offer women the opportunity to receive immunotherapy, often with chemotherapy, as their first-line treatment for metastatic disease. And there are some access schemes through some of the drug companies, but they're unfortunately at this point in time extremely expensive and really beyond the reach of most patients diagnosed with metastatic disease. PARP inhibitors, another exciting development. We know that BRCA1 and BRCA2 mutations are responsible for quite a small percentage of all women diagnosed with breast cancer, probably somewhere between 5 and 10% of all diagnoses. And we know that BRCA1 tumours are more likely to be triple negative. So there's been huge focus on trying to identify treatments that might target the specific genetic defect that BRCA1 and BRCA2 tumours have. And pleasingly, a group of drugs have been identified that can achieve this, and they're known as the PARP inhibitors. They are active for metastatic breast cancer and also for other tumours associated with patients carrying BRCA1 or BRCA2, namely ovarian cancer, pancreatic cancer, and prostate cancer. One of these drugs, known as olaparib, has been shown in a clinical trial called the Olympiad study that took patients who carried BRCA1 or BRCA2 and compared this with standard treatment with chemotherapy, and was able to show a really statistically significant improvement in what's called progression-free survival, so the time until that treatment stops being effective. So with chemotherapy, they saw the progression-free survival of just over 4 months, compared to 7 months for patients who were receiving olaparib. This drug also is currently not on the PBS. However, there are access schemes available, and it's certainly worth discussing with your oncologist if you do carry BRCA1 or BRCA2, whether you might be a candidate for an access scheme to gain these drugs. They're oral medications and they're generally very well tolerated. There are a number of also new exciting developments coming through in triple-negative breast cancer. So there's a drug called sacituzumab govitecan. I don't know who comes up with the names of these drugs, and they're always a challenge, so I'm going to call this one SG from this point forward. And this is one of the new class of drugs that we find as oncologists beautiful science. So essentially what it involves is an antibody which is targeted against a receptor that they have found can be seen on triple-negative breast cancer cells. This receptor is called TROP2. So the antibody glues to the TROP2 receptor, and then you can see those little tiny spheres of chemotherapy that are glued to the antibody are then released into the cancer cell, so allowing really high delivery of the chemotherapy within that cancer cell. The side effects are similar to chemotherapy, and this drug is not yet available on the PBS, but hopefully in the not too distant future this will be the case. And the ASCENT trial is a trial that looked at using this drug versus standard chemotherapy. And these curves looking at the overall survival of patients who've really had quite a lot of previous treatment for metastatic disease. And you can see that there was almost a doubling of their overall survival of receiving this drug compared to standard chemotherapy drugs. Finally, looking at HER2-positive disease, you can see in the little graphic that a normal cell has a few HER2 receptors on the surface compared to a HER2-positive breast cancer that is completely smothered in these receptors. And we're blessed in 2021 to have a number of drugs that are available that target the HER2 pathway. Some of these drugs, obviously, we're all aware of Herceptin or trastuzumab, which has now been around a long time, pertuzumab or Perjeta, Kadcyla or TDM1, or lapatinib, also known as Tykerb. And all of these drugs have a very standard order that we would usually approach using them for patients diagnosed with metastatic disease, but there's many clinical trials looking at new treatments in this setting. Pertuzumab is our standard first-line treatment used in combination with chemo and trastuzumab, and this, the clinical trial known as Cleopatra, was a really pivotal study that demonstrated this amazing survival of patients with metastatic breast cancer. So in the original paper, patients, the average survival was almost 6 years, and when this was presented many years ago, this was really a landmark paper. And this treatment is now absolutely in Australia the standard of care for patients diagnosed with metastatic HER2-positive breast cancer, with a difference of 15 months compared to chemotherapy and Herceptin alone. As I mentioned in triple-negative disease, the idea of getting an antibody such as trastuzumab and attaching it to chemotherapy is a very way to deliver high doses of chemotherapy into the cancer cell. And trastuzumab emtansine, also known as TDM1 or Kadcyla, is available on the PBS and works this way. There are newer drugs such as trastuzumab deruxtecan, which also has a similar antibody with Herceptin with the chemotherapy drug glued to it. And there are lots of clinical trials now moving forward as lots of other companies are also following suit and developing these drugs. So this is just graphically showing how our TDM1 works. You can see the HER2 receptor on the surface of the cancer cell and the Herceptin represented in the purple with the chemotherapy glued to it. Once the Herceptin binds to the HER2 receptor, the chemotherapy is released into the cancer cell, allowing really targeted effects. Another exciting new drug in the HER2-positive space is tucatinib. This belongs to a similar class of drugs to the lapatinib or Tykerb, as I mentioned before. And this is certainly recently found to be very active in a study called the HER2CLIMB trial, where they used Herceptin with oral chemotherapy plus or minus tucatinib, and they showed really significant improvements in patient outcome. What's really exciting about this drug is that, unlike most other therapies, as I mentioned, it certainly appears to have significant activity in patients who have brain metastases, and we eagerly await its availability for our patients through the PBS. But again, there are many clinical trials around Australia that may well allow a woman to access this drug. Neratinib is also another drug in the same class. There is an access scheme to access this drug, but it does have a lot of side effects, particularly diarrhea, that really mean it needs to be carefully managed. I wanted to briefly touch on personalised oncology. As I mentioned at the start, we're hoping, in the next 10 to 15 years to have really a lot of personalised oncology as the standard of care. So even though we've had standardised treatments for the particular subtypes of breast cancer, we know that breast cancer is even more complex than that. And so there's increasing use of molecular profiling tests to try and identify the genes that could specifically be driving an individual woman or man's breast cancer. These tests are not yet the standard of care in Australia, and you can purchase them, but they're extremely expensive and, again, really out of the reach of most patients diagnosed with breast cancer. It's important to note that many clinical trials do allow you to get access to these medications because they're trying to identify the patients that might carry specific gene changes. And I do believe in the next couple of years, many local companies may well develop these sort of tests at a much more reasonable price. So it's certainly, again, something to discuss with your oncologist. And finally, I just wanted to focus on clinical trials. As we've mentioned a number of ways through the talk, this is a really good way to potentially access new medications. And it's important to note that in clinical trials, usually the new drug will be compared with the current standard of care treatment. And if it is found to be superior, then can move forward to go on the PBS. But clinical trials are not for everyone. Some people really don't like the idea of being randomised on a trial and not being able to have a role in deciding which treatment they would receive. It's important to note as well that most clinical trials have quite strict criteria about who is eligible for their trials, and the sort of things that they look at may be other health issues that the patient has, and also how much previous treatment and what previous treatments the patient has received. And so it's important at each time point where a patient needs a new treatment that a consideration of a clinical trial is really paramount in the discussion between the oncologist and the patient. In the past, patients with brain metastases have often been excluded from clinical trials. And this is obviously a very distressing situation for those women who do and men who have brain metastases. But pleasingly, more and more trials are now considering eligibility of brain metastases, particularly if the disease has been treated. Just a small table looking at the pros and cons of participating in clinical trials. We do know that it allows potentially access to new effective treatments. And we know even if you get the control arm, which is usually the standard treatment arm, that patients are very closely monitored and there shouldn't be out-of-pocket costs. And clearly a patient can withdraw consent at any time. But the disadvantages of being on a trial are that you don't have a choice about your treatment, and you may not get access to the drug you are hoping for, and they certainly expect many clinical trials are really labour and time intensive for patients. So if you're trying to work or maintain a normal quality of life, that can be pretty challenging. And trials can be blinded, meaning both the patient and the doctor don't know the treatment the patient is receiving. So in summary, Patients with stage 4 breast cancer are now living much longer than ever before with their disease. And for many patients, it really is considered to be a chronic illness. However, still despite these advances, it is an incurable illness for most patients diagnosed with metastatic disease. We've had major advances in our understanding of the different biologies and targets in metastatic breast cancer. And some patients are really having very prolonged responses to treatment. And we hope potentially might even be cured with their current treatment, particularly with some subtypes of breast cancer, in particular patients with HER2-positive disease. But clinical trials are really our best way forward to try and identify new effective treatments. So at this point, we might go back to our polling, and I'm just going to report back what we found. So I'm really pleased to report that a majority of patients, nearly 90% of patients, did feel that they would consider participating in a clinical trial if it did allow them access to a new treatment. But perhaps somewhat disappointingly, 75% of patients reported that their oncologist had not discussed a clinical trial with them, with only 25% of patients saying that they had discussed a clinical trial with their oncologist. And I think patients with their voices should now move forward and make sure their oncologists are discussing with them any potential clinical trials that they might be candidates for. At this time, we might move forward with questions. And so I'm just going to read out the ones that have come through for me. So the first question is from Rita. And Rita asks about treatment recommendations for patients who have pleomorphic breast cancer, which is a particular subtype, pleomorphic lobular carcinoma that is triple negative and not driven by BRCA1 or BRCA2 or immunotherapy, and certainly has had some radiotherapy to bone metastases. So because that PD-L1, which can be a marker that immunotherapy is an effective treatment, was negative, unfortunately immunotherapy wouldn't be an appropriate treatment option in that setting. And really chemotherapy or any other trials that are looking at new exciting new treatments coming through would really be the standard of care in that setting. But it certainly sounds like all the appropriate investigations have taken place, which is fantastic. The next question is a really good one, is from Jennifer, and asked, will genetic testing become routine for metastatic breast cancer, and what are the implications? So genetic testing at the moment is restricted to women who meet certain criteria for free testing through state and federal governments. But you're absolutely right. We do believe as oncologists probably BRCA1 and BRCA2 testing should become the standard of care, because there are treatment options such as the olaparib, and some chemotherapy drugs certainly seem to be quite effective in patients who carry a BRCA mutation, so drugs like carboplatin. So I think we would certainly be advocating that hopefully in the not too distant future that becomes standard of care. Genetic testing's got a lot cheaper for the government over the last 10 or 15 years. So we would hope that that would be something that certainly becomes standard of care. The next question comes from Charla, and she asks about when are CT, PET, MRI scans and or bone scans ordered, i.e. indications for one over the other? Another really good question. So for certain subtypes of breast cancer, PET scans certainly would be considered standard of care for women diagnosed with metastatic breast cancer. So typically for triple negative breast cancer and HER2 positive breast cancer, those tumours that are dividing more quickly, PET scans are certainly give us the most information about the extent of metastatic disease. For some hormone-driven breast cancers, particularly those that are really slow growing, PET scans are sometimes negative, and CT scans and bone scans would be considered more informative tests. But often these patients might have one PET scan to see if their disease does light up on a PET scan. And if it does, then moving forward, that's also going to be a useful modality. MRI scans are typically used for more localized areas of the body, particularly the brain, and certainly would be the most effective sensitive test for looking out for brain metastatic disease that we would utilise. And then the last question was really looking at pertuzumab, asking, will pertuzumab ever be available as an injection? So I am guessing this question's come from Sarah, and I'm guessing that, Sarah, you're talking about subcutaneous injection, and that's, again, another really good question. Herceptin or trastuzumab can be given as a subcutaneous injection, but currently in Australia, pertuzumab is not indicated in that setting. I understand overseas it certainly is administered this way, and I would truly expect that it will be not far away that we are also using pertuzumab as a subcutaneous injection. And clearly there's huge advantages for the patient if we're able to give these treatments in a subcutaneous way, because that does hopefully keep the patient out of the hospital environment. There are certainly services where hospital in the home or other services are able to provide the injections in the home environment. And finally, the last question is from Ursula, who's asking about having to fund olaparib, which she's finding, of course, a very expensive medication. And so there are other genes apart from BRCA1 and BRCA2 where olaparib may well be of benefit, such as the PALB2. And we would certainly be advocating that when we do get a PBS listing, hopefully it's available for all women diagnosed with genetic cause for their breast cancer, if there is evidence that olaparib would be of benefit to those patients. And it really is an absolute tragedy. I always say to my patients, it would be, I hate talking about money during consultations. That is not what oncology is about. If there are drugs that are available that there are out-of-pocket costs, I will discuss them with my patients, but I absolutely ask them to have complete honesty with me about whether that is something that they could afford. And I certainly would never want a patient to feel that they're being pressured by their treating team to find money to support a treatment that really we would hope anytime soon should be funded through the PBS. And another question coming through from Terry. How long can you expect palbociclib and letrozole to be effective treatment? Would you then move to ribociclib or similar treatments? Again, a really good question. The average time that one of these combinations of using letrozole with palbociclib being effective is somewhere between 1 and 2 years for the average woman, but clearly there's a huge spectrum within that time frame. And some patients may have a quite short benefit from this treatment, and some patients may actually have benefit that extends on really for a number of years. There are ongoing clinical trials to establish if moving from one treatment to the next would be of benefit to patients. But certainly currently that's not allowed through the PBS in Australia. Again, that might be something that a patient finds a clinical trial where they're looking at continuing on with another CDK4/6 inhibitor after one of them becoming ineffective, but it's certainly not standard of care. And typically we would look at other pathways like the PI3 kinase pathway to try and target a different way to attack the cancer once the letrozole and palbociclib have become ineffective. Everyone is very informed. I'm really impressed with the standard of the questions. It's really high. The next question is from Jill, who asks, do I know how far off tucatinib is for general use? And the short answer, I'm sorry, is I'm really not sure. It's a very involved process, and Kirsten could probably give you far more information about how complex the process is to get a new drug on the PBS. It's a very involved system that often takes months, if not years, even after the clinical trials showing the benefit of these drugs have been published. And obviously, oncologists in Australia, when we now virtually attend meetings, that are looking at new treatments overseas. We become really excited about being able to offer these treatments to our patients, and then really frustrated when there's this lag time before they do become available through the PBS. And again, I would just encourage women to have a look at clinical trials that are open around Australia to see if there really are any trials that they would be a good candidate for. The next question's from Madeline, and asks, why are patients diagnosed with de novo metastatic disease? So there's a lot of the biology of breast cancer that we genuinely don't understand. Why some cancers metastasize early and spread to other parts of the body, whereas other cancers might grow to be very large in the breast and never spread to other parts of the body, is part of the unanswered question about metastatic disease. And there's a lot of research going on to try and understand why these different tumours have this different biology. Sometimes we can reach a circumstance where the primary in the breast is almost not detected, but the patient presents with widespread metastatic disease. And this is, of course, a really devastating situation for the woman, because sometimes this metastatic disease is symptomatic, but certainly sometimes it comes as a complete shock. And the patient has to go from thinking they're about to have surgery that will treat the breast cancer to a situation where they are receiving treatments that are hoping to allow them to live longer but not be able to cure the illness. So another really good question. And the next question is from Rona, who's wondering about the prognosis or chance of 5-year survival for patients diagnosed with a single brain metastasis in the frontal lobe. It's obviously not the place of this presentation tonight to be providing prognostic information to an individual woman in this situation. And there are a whole lot of variables that would really dictate that individual woman's prognosis related to the subtype of breast cancer, the treatment she's received for that single brain metastasis. But I would certainly point out that in 2021, we take a very aggressive approach for brain metastatic disease, far more aggressive than we ever have before. And treatments like surgery or very localized stereotactic radiation are really our first approach, if we can, for women with metastatic disease. And that repeated scans and monitoring the situation very carefully would be our aim during that time. So I'm sorry I'm not providing more information, but it would be certainly something that I'd encourage each individual woman to discuss with their oncologist. The next question is from Andrea. And the question was, how often should metastases be biopsied? Should this always happen at disease recurrence or treatment failure? And what role do blood biopsies play? Another good question. So we would always, as I mentioned earlier, we would always try and get some tissue when a woman does relapse from metastatic disease. But sometimes that's not possible to do. Sometimes the lesions are too small or in precarious places where the risks of the biopsy are too high and it's not possible to do a biopsy. But every endeavour would take place to try and get some tissue. And I think if a patient, over the course of a patient's metastatic disease, there would be a number of times where the patient or the doctor might suggest that repeat biopsies take place, certainly to ensure the biology has not changed. Blood biopsies or liquid biopsies certainly are having an increasing role, currently in Australia, mainly in a clinical trial setting, but do allow detection of mutations. And this is certainly going to be a space to watch, as clearly it's a lot easier to get blood than to subject a patient to a biopsy, which can be a very distressing and sometimes very painful experience. And I think at that point we will stop. Thank you all for listening to the presentation tonight. I hope it met some of the needs you had in discussion about metastatic disease. Thanks.
Good evening, everybody. Welcome to this session. My name is Belinda Kiley and I am a medical oncologist working in 2 hospitals in Sydney at Campbelltown and Concord. And as many of us are tonight, I'm currently in lockdown. I'm going to be talking about treatment for early breast cancer. So for the next 30 minutes or so, I'll be trying to just cover most of the general aspects about the treatment. And then the last 10 minutes, we're going to have an opportunity for you to all put in any questions you have, and I'll try and answer them. So essentially, I've just sort of gone through what some of the common questions are in early breast cancer, going through the diagnosis, the treatment, and then the prognosis. So I think one of the big things I often get asked is about when should I have a PET scan? What's the role of PET scan? Also other scans. So I think when someone is first diagnosed with an early breast cancer, and that's a breast cancer that is confined to the breast, and sometimes it's also in the lymph nodes under the arm, we will often perform scans to check whether there's any sign that the cancer spread to other parts of the body. Now, we don't do these scans on everybody. It's really for the people that we think there's a higher risk that it may have spread. So generally high-risk cancers are those where the cancer size was large, or there were quite a few lymph nodes involved, or in someone who has some symptoms that might be a sign that there could be spread of the cancer. So not everybody needs to have a scan. If we do recommend doing a scan, then that can be either a CT scan, which typically would look at the lungs and the liver, and a bone scan to look at the bones, or we can do a PET scan. So I guess the advantage of the PET is it's just one scan and it kind of looks at what the CT and the bone scan look at, but you don't have to do the PET scan. You can do the CT and the bone scan. The PET scan still has radiation, so the main benefit is it's just the one scan. The PET can be a bit less accurate in some of the low grade and lobular type breast cancers, so sometimes the CT has an advantage in that setting. And PET scans are reimbursed through Medicare for staging of locally advanced breast cancer or evaluation of suspected metastatic disease. So they really aren't reimbursed for people that have got very small lymph node negative early sort of stage 1 and 2 breast cancer. So it's really the big cancers with positive nodes that we're more worried about, or if we've got a suspicion of metastatic disease. So I guess not everybody needs a PET scan. So what's the aim of treatment in early breast cancer? And I think what I like to say is that what we're trying to do here is improve the length and quality of life of people with cancer by getting rid of or eradicating all the cancer cells. So we know that the cancer starts in the breast, and for a lot of people, just removing that tumour, they're going to be cured. But for some people, cancer cells can escape out of the breast and can travel either through the lymphatic channels or through the bloodstream into other parts of the body. So the idea of a medical oncologist giving treatment either before or after the surgery is to try and clean the blood of any cancer cells and stop the cancer coming back later somewhere else in the body. So the way we do that, I guess the main treatments we use are chemotherapy, which in early breast cancer is always intravenous, unfortunately. There's no oral options. And it typically would run for between 3 to 6 months. Now, we give chemotherapy again to the higher risk cancers. Trastuzumab, or the brand name Herceptin, is given to people that have HER2 positive breast cancers, and it runs for 12 months, and it can be intravenous or subcutaneous injections. And this has to be started with chemotherapy. So anyone that requires Herceptin also has to receive chemotherapy. And that's because it works best in combination. The other big group of treatment is the endocrine or hormone blocking therapies, and they are tablets in early breast cancer. And we recommend these for any hormone receptor positive cancers. So that's the estrogen and progesterone receptor positive cancers. And these tablets typically are taken for between 5 and 10 years. The other treatment we're also using increasingly in early breast cancer is this group of drugs called bisphosphonates. And some of the names of these, one of them is zoledronic acid. These are actually drugs that are used traditionally to treat osteoporosis or bone thinning, and they're quite effective in preventing fractures. but they have also been shown to be effective in breast cancer. So each of these treatments reduces the risk of the cancer returning. So the chemotherapy reduces the risk a little bit. If you add on the trastuzumab or the hormone therapies or the bisphosphonates, each of them brings down that risk of recurrence a little bit. Now, I am talking about early breast cancer, but I just thought I'd mention male breast cancer briefly. It only represents about 1% of all breast cancers. So the lifetime risk of breast cancer for a man is actually 1 in 1,000, whereas for women, we know it's 1 in 8 or 1 in 7 sometimes. The average age at diagnosis for men is 67, whereas for women, it's a bit younger at 62. What is different about male breast cancer is nearly all male breast cancer is hormone receptor positive, whereas for women, it's more like 60 to 70% is hormone positive. Risk factors for male breast cancer, like with women, it does get more common as you get older. There are some genes associated with male breast cancer, typically the BRCA2 gene. People with mutations in that have a higher risk of breast cancer if they're males. Radiation exposure, so men who have had radiotherapy to their chest for other cancers can get breast cancer. And also increased estrogen or enlarged breast tissue in men predisposes them to breast cancer. The way we treat male breast cancer is exactly the same as how we treat female breast cancer. So tamoxifen is actually the preferred hormone therapy, but aromatase inhibitors can still be used. And we still use chemotherapy, trastuzumab, and radiotherapy. So the treatment is actually very similar. So in these slides, when I'm referring to treating early breast cancer, I'm actually referring to how I would treat men and women with breast cancer. So the type of treatment we recommend really does depend on the type of breast cancer that someone has. And I've just put the main types of breast cancer up here. So triple negative means that it's negative for the 3 receptors, estrogen, progesterone, and HER2. Because this type of cancer is negative for those receptors, we can't target any of those receptors with treatment. So really the only treatment available for someone with triple negative cancer is chemotherapy. HER2 positive cancers receive chemotherapy, but they also receive Herceptin, and some can also receive another drug called pertuzumab. And if these HER2 positive cancers are hormone receptor positive, we also recommend hormone blocking therapy. And then any breast cancer that has positive hormone receptors, we recommend hormone blocking therapy. And in hormone positive cancer that is high risk, these people we recommend chemotherapy and hormone therapy. So you can see the decisions about what treatment really do differ by the type of breast cancer. So how do I decide how risky someone's cancer is and whether or not to give chemotherapy? So we recommend chemotherapy for high-risk cancers, but what's a high-risk cancer? So the features that I sort of think of when I see a new person with breast cancer, is it involving the lymph nodes under the arm, so the axillary nodes? Because if the cancer in a way has been clever enough to spread into those lymph nodes, it's a little bit more likely that it's also been clever enough to spread to other parts of the body. So it is a higher risk feature. Also, if it's hormone receptor negative and I know I won't be able to use hormone blocking therapy, then I'm going to be more likely to use chemotherapy. If a cancer is high grade or very large, it's a bit more likely to be a higher risk cancer. HER2 positive cancers in general are higher risk. And younger women as well can often have a higher risk type of cancer. Low risk cancers are the opposite: lymph node negative, hormone receptor positive, small, low grade, and in postmenopausal women. There are also some online calculators that help us to determine the risk of cancer recurrence and death. And one of these that I often use is called Predict. And this is based on a large population of people in the UK who have been treated for cancer and then followed up to see how many had a cancer recurrence, how many died, what treatment they had. So it can give you a bit of an idea of how people with a similar sort of cancer and if they're a similar age and having similar treatment, it'll give you percentages of the benefit. And I'm just showing a screenshot here of the information that Predict can provide. So here I've entered the data to say I've got a 45-year-old woman with a 20 millimeter cancer with one positive lymph node, and it's hormone positive. And what the Predict program will tell me based on other women with those same features, you can see here that it's telling me out of 100 similar women, 91 will be alive at 5 years if they have no treatment except for surgery. But if I give those women hormone therapy, you can see in 5 years, an additional 2 women will be alive. And if I give these women hormone therapy and chemotherapy, an extra 5 women will be alive. So it does help to sort of work out, should I have chemotherapy or just hormone therapy? Because you can see here the chemotherapy is saving an additional 300 women. And so for many women, when I have a conversation like this, they'll say actually for a 3% benefit, I would like to have the chemotherapy. So this program is helpful in trying to quantify the benefit of treatment and the risk of recurrence. The other way we do this though is through what we call multi-parameter gene expression assays. Now, these are sort of tests that are done on the tissue that is removed during cancer surgery. So when your breast cancer is removed, the tissue goes to the pathologist. A sample of that tissue can be sent for further gene expression testing. And these tests can also predict the likelihood of a cancer returning and help to make decisions about whether to have chemotherapy. So these tests are really something we would think about in a cancer that was hormone receptor positive and HER2 negative. So we don't use these for triple negative or HER2 positive cancers because those cancers are higher risk and need chemotherapy. It's really the hormone positive cancers, and we're trying to work out, do they just need hormone therapy or should we give chemotherapy and hormone therapy? And the most evidence for these tests is actually in postmenopausal women who either have no lymph nodes involved or up to 3 lymph nodes involved. Unfortunately, these tests are not available in Australia reimbursed at the moment. So there is an out-of-pocket cost. Depending on the test, that ranges from $3,000 to $5,000. The most common one you may have heard of is Oncotype DX that's performed in America, but there's also EndoPredict and ProSigna that are performed in Australia. And these tests are all pretty similar in the information they provide. The Oncotype DX test has got a little bit more evidence behind it based on real women who have had the test and had decisions about chemotherapy made based on the test result. So this big trial called the TAILOR-X trial was a big American study where they had thousands of women and they all had ER positive breast cancers and they all had surgery and they had no lymph nodes involved. So they were node negative. And they had an Oncotype DX done. And if the score was very low, they just had hormone therapy and they actually did very well. 97% of them were alive and well after 9 years. So those women don't need chemotherapy. If the women had a very high risk score on the Oncotype, greater than 25, those women had chemotherapy and hormone therapy. And you can see nearly 90% of them were still alive at 9 years, but they did require the chemotherapy. And then the study randomized women with an intermediate score. So if their score was between 11 and 25, they were randomized to have hormone blocking therapy alone or hormone blocking therapy and chemotherapy. And what they found is that in these women, there was no difference in their outcome. So essentially this study tells us that if you have a lymph node negative hormone positive cancer and you have a recurrent score less than 10 or up to 25, you really just need hormone blocking therapy. If the score's over 25, you should have chemotherapy. So this is where an Oncotype DX test can be helpful. If it's this sort of cancer, hormone positive, node negative, it can help make that decision about whether or not to have chemotherapy, but the test is very expensive, so it's certainly not routine at the moment. So just summarizing this again here, when is it helpful to have an Oncotype DX? It's for hormone positive, HER2 negative cancer. In premenopausal women, it's not as well established that this is effective and safe. The cutoff for low risk is actually a little bit lower. So you can see with the premenopausal women, we think if the score is less than 16, hormone therapy only, whereas for the postmenopausal women, less than 26, hormone therapy only. If it's greater than or equal to 26 in a postmenopausal woman, we recommend chemotherapy. In a premenopausal woman, we're starting to talk about chemotherapy when it's 16 or above. So the other thing I wanted to talk about was neoadjuvant chemotherapy, which is when we give chemotherapy before surgery. Now, this is becoming a lot more common. So traditionally, it used to always be do the surgery first, then follow it up with chemotherapy. But increasingly, we're using more chemotherapy before surgery. And the main benefits of doing this are that the surgery can be less extensive. So if you start with a very large cancer and we give chemotherapy and that cancer shrinks a lot, it may be possible that rather than having to have a mastectomy, you can just have a lumpectomy to remove the cancer. It's also quite good because it allows us to look at how well the chemotherapy is working. So if a cancer is shrinking, everybody feels good because we know that the treatment's working, the cancer's getting smaller, this person's going to do well. I think if you have the surgery first, there's no way of judging if the chemotherapy is working. So there's always that question, is the chemo working or not? With new drugs coming through, giving the treatment before surgery also allows us to work out if the new drugs are effective, because again, we can give the new drugs and then see how many people get shrinkage of their cancer. So there's a lot of research and new drugs are being evaluated in this sort of neoadjuvant pre-surgery space. The other benefit of having chemotherapy before surgery is it allows time to think about the type of surgery you want to do. So I think when someone is first diagnosed, there's often this alarm, this urgency. A lot of women just say, I want to have both breasts removed straight away. Whereas if you have time to think about it and you do the 3 or 6 months of chemotherapy, you might then sort of recognize, actually, I don't want to do both breasts removed. I am happy to try and do a lumpectomy, or yes, I want to do a mastectomy, but I want to look into the options for reconstruction. And you've got a bit of time to do that. The other thing it provides time for is genetic testing. So for women where we think they should have gene testing, they can do that genetic testing, and that actually also might influence the type of surgery they do. So if someone's found to have a gene mutation that increases their risk of breast cancer, they may decide that they want to have a mastectomy, whereas if they don't have a gene mutation, they might be happy to proceed with a lumpectomy. So that bit of extra time to make the decisions about surgery can be helpful. The main thing to say, though, is that really if you do the chemotherapy before the surgery or after the surgery, there's no big difference in your chances of cure or your chances of surviving the cancer. So the main benefits are those listed. It doesn't really change your chances of cure. The cancers that we really like to use this neoadjuvant chemotherapy for are those where chemotherapy works best, and this is the triple negative and HER2 positive cancers. So in these cancers, we are sort of predominantly now using chemotherapy before surgery. And if we have a very large cancer, so someone has a large cancer, regardless of the type of cancer, we'll often try chemotherapy to make it a bit smaller because it does make the surgery easier. In the HER2 positive and triple negative breast cancers, if we do the chemotherapy before surgery, we will then often talk about giving extra treatment after surgery, depending on how well the tumour has responded. So one of the benefits, as I said before, of doing chemotherapy before surgery is you can look at how well the cancer has responded. If when you have your breast cancer surgery, they remove the tumour and actually there's no cancer cells there anymore, they've all gone, the chemotherapy killed them all. If the cancer's HER2 positive, those people just continue with Herceptin. If it's a triple negative cancer, there's no more treatment or chemotherapy for those people. However, if there are cancer cells in that tissue that's removed at the time of surgery, then for the HER2 positive cancers, we actually talk about changing from Herceptin to another drug called Kadcyla or TDM1, because that has been shown to be more effective in preventing the cancer returning than continuing with Herceptin. And in triple negative cancers, if they have cancer cells left that are removed at the time of surgery, then rather than doing no treatment, we would actually talk about using tablet chemotherapy for 6 months with a drug called Xeloda or capecitabine, because that's also been shown to be effective in preventing cancer returning. So you can see that for these two types of cancer, HER2 positive and triple negative, one of the benefits of doing the chemo before surgery is it then allows us to work out whether or not we should be using this additional treatment after surgery. If you have the surgery up front, we just don't know whether or not these treatments would be effective. So if someone's having chemotherapy at a young age, so when they haven't gone through menopause yet, the chemotherapy can damage the ovaries, and that can cause them to go into menopause at an earlier age, and it can cause infertility. So this is quite an important consideration in young women having chemotherapy. The risk of going into early menopause and becoming infertile increases with age. So the older you are when you have the chemotherapy, the higher the risk that the chemotherapy could cause an early menopause. Any women who are young, who need to have chemotherapy, who still would like to have children, it's important that we discuss this before you start chemotherapy. And these women should be referred to a fertility specialist. And it is quite safe to have IVF before starting chemotherapy to try and save some eggs or embryos that can be used later after the cancer treatment has been finished. The other thing we often do though as well is we can give monthly injections called Zoladex during the chemotherapy, and this reduces the risk of damage to the ovaries. So the chemotherapy typically damages cells that are rapidly dividing. So if we turn the ovaries off with these Zoladex injections, they're less susceptible to chemotherapy damage. So studies have shown that women who receive Zoladex during their chemotherapy have less risk of going into early menopause and having no periods after their chemotherapy, and they're less likely to be infertile. And these studies have shown an increased likelihood of getting pregnant after treatment. So for young women who want to prevent early menopause or try and maintain their fertility, as well as recommending IVF before chemotherapy, we will often recommend Zoladex injections during the chemotherapy. And this can be for any type of breast cancer, so hormone positive, triple negative, HER2 positive, it doesn't matter. These injections are safe to give in all those types of breast cancer. So moving on now to the hormone blocking treatments, which are very commonly used in early breast cancer. And I've just got the two main types up there. So tamoxifen, which works by blocking estrogen uptake, and it can be used in women of any age. The aromatase inhibitors work by decreasing estrogen production, and they only work in postmenopausal women. So they don't work in women who have ovaries that are still working. Now, when they've been compared head to head, the aromatase inhibitors are slightly more effective than tamoxifen in reducing the risk of the cancer returning. So when they've been compared, the aromatase inhibitors have a 3% lower risk of the breast cancer returning and a 2% lower risk of someone dying from breast cancer. But the aromatase inhibitors also often have more side effects. So I think it's just a matter of weighing this up. So certainly they're a little bit more effective, but the benefit is small. And I think if you're getting a lot of side effects, it may not be worth it when the benefit's so small. Tamoxifen is still a good drug. If that agrees with you more, then that might be a better option. So what are the side effects of hormone blocking treatments? With tamoxifen and the aromatase inhibitors, the most common side effect is hot flushes and sweating. With tamoxifen, it can also cause a vaginal discharge. Rare side effects of tamoxifen, it does increase the risk of blood clots such as DVTs in the legs and lung blood clots, pulmonary emboli. Tamoxifen very rarely increases the risk of uterus cancer. It's really only in women over the age of 50, so in young women that's not going to happen. And it can increase the risk of cataracts, but again, these are rare side effects. Aromatase inhibitors can cause joint pain and stiffness, which is actually quite common, vaginal dryness and reduced libido or reduced interest in sex. The aromatase inhibitors also increase the risk of bone thinning and fractures, and they can increase cholesterol levels. And some women find that the aromatase inhibitors cause a bit more hair thinning. How long should you stay on these hormone blocking therapies? So I think the minimum time recommended is 5 years. So I think if someone asks this question, I'll always say at least 5 years. With tamoxifen, they have looked at taking the tablets for 10 years compared to 5, and there is a small additional benefit. So if someone has stopped at 5 years versus stopping after 10 years, the longer duration does further reduce the risk of the breast cancer coming back, and it's about a 3% reduction. And it also has about a 3% reduction in someone dying from breast cancer. But that benefit doesn't seem to happen until 10 to 15 years after the diagnosis. So if you're 90 or 85 when you're diagnosed with your cancer, then maybe 5 years is going to be enough for you, because by the time you're 105, you're probably not going to be that worried about your cancer coming back. But if you're younger, then if you're tolerating tamoxifen well and you finish 5 years of treatment, it actually may be something to consider, because there is that small 3% reduction in the risk of cancer returning and dying from breast cancer. Now, there is that slightly higher risk of blood clots and endometrial cancer to think about, but even in the study where women took tamoxifen for 10 years, the risk of those things was very rare, and the benefit for the breast cancer was still bigger than those risks. With aromatase inhibitors, the evidence is not as strong. So certainly there has been some studies looking at 10 years versus 5 years. And in the 10 years, in the people that took the tablets for 10 years, there was a 4% reduction in the breast cancer returning. There hasn't yet been shown any benefit in the number of women surviving. And the main risk of continuing the aromatase inhibitors is it does increase the risk of fractures and osteoporosis. So I think the reason we think about extending the hormone blocking therapy is that we know in hormone positive cancer, the cancer can come back after those first 5 years. And in fact, 50% of the women who have a recurrence will have that recurrence after 5 years. So that's why we do think about continuing the treatment for longer, but the benefits are small. So I guess I think about 10 years of hormone therapy. If someone isn't having too many side effects, if their cancer is higher risk, because then they've got a higher risk of it coming back, and that goes back to those features we mentioned earlier, the positive lymph nodes, high grade, larger cancer. And really, because the benefits are sort of seen 10 to 15 years down the track, you want someone who's going to live at least 10 to 15 years to see the benefit. So that's kind of how I decide who to give longer duration therapy to. There's been no evidence of a benefit for taking these tablets longer than 10 years. So 10 years really is the maximum. So moving now to premenopausal women. So women who are typically still having periods when they're diagnosed, they're usually under 50. There's been a study done looking at what the best hormone blocking therapy is for premenopausal women with hormone positive breast cancer. And this study was actually led by Prue Francis, one of the oncologists in Melbourne. So this soft study was one that she designed and ran, which is amazing that we had an Australian running a big international study where thousands of women were enrolled. And these women were randomized to either receive tamoxifen by itself, tamoxifen and Zoladex injections, and these Zoladex injections turn off the ovaries and put the women into temporary menopause, or an aromatase inhibitor with the Zoladex injections. And you can see just these numbers down the side of the screen, that the number of women alive and well after 8 years of follow-up, the percentage increases as you add the Zoladex and as you use the aromatase inhibitor. So all of these treatments are effective, but certainly adding Zoladex to tamoxifen is a little bit more effective. Having Zoladex and aromatase inhibitor is a little bit more effective again. And the benefit was greatest in the women who were under 35 and the women who had cancers that were high enough risk to need chemotherapy. So for a lot of young women now with hormone-positive breast cancer, we do talk about having Zoladex injections in combination to their hormone-blocking tablets. And some women may choose to have their ovaries removed, which gives a similar benefit to the injections. But the problem of the hormone injections is increased side effects. And so I'm just running through a few of the common hormone side effects and how we can better manage them. So I think hot flushes is a very common one. How do we manage that? There are sort of medication approaches and non-medication approaches. So some of the non-medication approaches, a lot of you are probably familiar with: layering your clothing, using a fan, having a cold drink, avoiding obvious triggers. There has been some data that hypnosis may be helpful. And then the pharmacological or the medication treatments that have been proven to be effective for hot flushes are actually medications we use for other things. So antidepressants, some of them, particularly a drug called Effexor, oxybutynin, which is actually used for bladder or bladder incontinence, can actually work for hot flushes, and gabapentin. So these three drugs have all been shown to be effective for reducing hot flushes and can be useful and can be combined safely with hormone blocking tablets. If you're having a lot of joint pain or bone pain, what can help that? Exercise and acupuncture have been shown to help, but also switching from an aromatase inhibitor, if that's what someone's taking, to tamoxifen can be very helpful. Duloxetine is an antidepressant that can help with joint pain, and then simple things like paracetamol. One of the other common symptoms for women on hormone blocking therapy is vaginal dryness or painful sex. And what can help there is using moisturizers and lubricants. Again, these side effects are usually less with tamoxifen than the aromatase inhibitors, so sometimes switching to tamoxifen can help. And we also do sometimes use low-dose vaginal estrogens. Sleep disturbance and fatigue are two of the other common symptoms that can often respond to exercise. So moving to the HER2-targeted therapies, the main drug that you might be familiar with is a drug called Herceptin or trastuzumab. So about 15% of breast cancer is HER2 positive, and it's only these HER2 positive cancers that the Herceptin will work in. It does need to be started with chemotherapy, and adding Herceptin to chemotherapy has been shown to reduce the risk of these HER2 positive cancers returning. The main risk of the HER2 targeted treatments is there is a small risk of heart damage in about 10% of women. The good thing about the Herceptin related heart damage is it tends to be reversible, which means if you stop the Herceptin, usually the heart will recover. So it doesn't tend to cause permanent heart damage. The other HER2 targeted therapy you may have heard about is a drug called pertuzumab or Perjeta. Now, we do use this in early breast cancer. Typically, it is given in combination with the Herceptin and chemotherapy, and it's given before surgery. So the main advantage of using this drug, Perjeta, is that it can increase the chances of the cancer shrinking. So when we're giving that treatment before surgery, we're trying to shrink the cancer down, and a lot of cancers will shrink very well with Herceptin and chemotherapy alone. But if you add the Perjeta, it may shrink a little bit more, particularly for the hormone negative HER2 positive cancers. The problem is that this drug is not reimbursed currently in Australia. So again, it's not sort of standard therapy. It can be paid for. There is a cost sharing scheme available, but it does still cost several $1,000s. So it's not a drug that I'd be saying everybody should receive. Now just moving to the bisphosphonates. So these are the bone-targeted therapies I mentioned at the beginning. They're traditionally used for osteoporosis, and the one that we're using quite a bit of now in early breast cancer is this drug called zoledronic acid. So it does work very well in stopping fractures and preventing osteoporosis. But when they've done studies on women with early breast cancer and they've given them this zoledronic acid, they've given it to protect their bones, but they found quite unexpectedly that these women had less breast cancers returning and were less likely to die from breast cancer. But it only seemed to be working in the postmenopausal women, so the women that were no longer having periods. So the way we give this is it's given intravenously every 6 months, and the recommendation is to do it for between 3 to 5 years. It does have some side effects. Some people get quite bad infusion reactions, whereas for a few days or a week afterwards, they can have fever, bone pain, nausea, feel quite unwell. Typically that recovers, and the subsequent doses of this don't cause the same reaction. And there's a very small risk of a rare sort of jaw infection that can happen if you have any teeth pulled out while you're on this drug. It's not on the PBS, but a lot of people can access it fairly cheaply through most hospital pharmacies. It costs around $30 a dose. So it is a benefit for your bones, and it can also help with breast cancer if you're postmenopausal. So we're now sort of using this quite a bit, and that can be in any type of breast cancer. So just quickly now on to follow-up after breast cancer. If someone's finished their main treatment, what we recommend for imaging is really just annual breast imaging. So that's the mammogram, and some women do an ultrasound as well. That should be done every 12 months. And the main role of that is to pick up any new breast cancers. We also want people to be aware of any what we call red flag symptoms, because these may be a sign of the breast cancer coming back somewhere else in the body. I've listed some of these here. So headache, bone pain, cough, nausea. They're really symptoms though that persist. So I think everybody gets headaches and coughs and pains, and they come and they go. What worries us is a symptom that's new and persisting and getting worse with time. That's the sort of symptom that we want you to tell us about. But if someone hasn't got these symptoms and they're feeling well, there's no role for doing blood tests, tumor markers, or scans for cancer. We really only do those things if someone has a symptom. So really, there's no sort of special scans besides just doing a mammogram and an ultrasound every 12 months. Now, just quickly onto prognosis or survival rates. I guess the good thing about early breast cancer is with all the treatments we have and the mammograms and the techniques in picking up cancer early, most women that we see these days with early breast cancer will be cured. And we're seeing 5-year survival rates up to sort of 95% or more. I think for the hormone positive cancers, the risk of recurrence is highest in the first few years, but then there's this low risk of recurrence that does persist. Even out to 20 years is a very small risk of it returning. Different to the hormone negative cancers, where really there's a high risk in the first few years, but then after 5 years, it's very rare for these cancers to return. So with a hormone negative cancer, after 5 years, you're most likely being cured. That's the end of my talk. So I would like to sort of answer any questions. If you have any, please put them up in the chat room or write them in, and I'll just stop sharing my screen. I can see there's a question here from Janine asking, what can you do for someone who cannot have chemotherapy because of other health issues, but they have a higher risk cancer, like positive lymph nodes? So good question, Janine. It's really difficult. I think in that case, if someone really wasn't safe to have chemotherapy, I'd probably be doing all I could to maximize the treatment they could have. So if it was a hormone positive cancer, maybe I'd be trying to get them onto an aromatase inhibitor rather than tamoxifen. I'd be trying to get them to have 10 years rather than 5 years of hormone blocking therapy. And if it was someone that was postmenopausal, I would also talk to them about having the bisphosphonate treatment, zoledronic acid, every 6 months, because each of those things is going to bring down their risk of the cancer returning a little bit, and that might actually make up for the benefit they're missing out on with chemotherapy. If it was a younger woman who couldn't have the chemotherapy because of other health issues, and it was a hormone positive cancer, I would like them to have Zoladex injections to turn their ovaries off and combine that with an aromatase inhibitor, because that's a bit more effective than just having tamoxifen. So I guess I'd be trying to maximize the other treatments that were available, but it is very difficult. And these are the sorts of conversations I have every day with people trying to work out whether or not to give chemotherapy. I have another question here from Christine asking, why are hormone blockers generally started after chemotherapy? Why aren't hormone blockers started early as possible during chemotherapy? Another great question. You would think if we're trying to target the hormone positive cells, we should be starting them early. I think that Previously, they did look at giving tamoxifen during chemotherapy, and they saw a higher rate of blood clots. So that's not safe because chemotherapy can make your blood a bit stickier. Tamoxifen makes the blood a bit stickier. So certainly I wouldn't want to combine tamoxifen. But aromatase inhibitors don't have that clotting risk, and they actually may be safe to give with chemotherapy. And again, back to our favourite Australian oncologist, Prue Francis in Melbourne, she's actually just run a study looking at this question where she's given patients with early breast cancer chemotherapy, and half of them got hormone therapy started with the chemo, half of them got it started after the chemo, and they received an aromatase inhibitor. So we haven't got the results for that study yet, but if it comes back showing that it's safe, and in fact, if it's even more effective, then in the future, that might be what we're doing. But at the moment, until we get those results, we're going to be giving the hormone therapy after chemotherapy. I've got another question asking, is Oncotype DX the same as genomic profiling? Yes, it is. It's just one of the tests available to do genomic profiling. And Roz asked, can I talk about radiotherapy after surgery? Roz, I'm a medical oncologist. I talk about all the drugs because that's what I give every day. Radiation, you need to talk to one of the radiation doctors, but I'm not sure if you had a specific question, Roz, but essentially women that get radiotherapy are typically women who have had just a lump removed. So if you've had a lumpectomy, you will generally require radiotherapy after your surgery. If you've had a mastectomy, higher risk people get radiotherapy. So again, it comes down to big cancers and positive lymph nodes. Tash has asked, have I had much experience with people with mixed type tumours? I was originally diagnosed with ER, HER2, early breast cancer on a biopsy, and then treated, and then at lumpectomy, they found a small triple negative cancer. Yeah, we do see this sometimes, Tash. Sometimes I think the treatment can change the cancer. It's possible that the treatment killed off the hormone positive cells and what was left was the triple negative. So it is something we do see. And as we're using more triple negative chemo, we are actually seeing some people with a difference in the cancer pre and post. And I guess it's just working out. We don't really know then what to do with treatment, but I guess if it started off hormone negative and then became hormone positive or HER2 positive, I would want to give treatments for those receptors. If it turned to triple negative and you'd already had chemotherapy, there's probably not much else I would do, but you could give maybe capecitabine after surgery. Tiana asks, should mammograms and ultrasounds still be done annually for people who have had double mastectomies? No. If you've had a mastectomy, you don't need to have breast imaging. So really, after a mastectomy, what we want you to do is just keep a watch on the skin, check the scar, check the skin, any changes, rashes, new lumps, we want you to tell us, but we really don't need to be doing mammograms and ultrasounds. Julie asks, why do some only get radiation and not chemo with low grade? So I think it goes back, Julie, to that slide I showed about working out what's a low risk cancer, what's a high risk cancer. And so if the cancer's low risk, we don't need to give chemotherapy, but it's possible if someone's had a lumpectomy, even though it's a low risk cancer, they don't need chemotherapy, but they still need radiotherapy. The main role of the radiation, I guess, is to stop the cancer coming back locally in the breast tissue area. The main role of the chemotherapy is to stop the cancer coming back somewhere else in the body. So if the cancer is low risk, we don't think it's going to come back somewhere else in the body, but it may still have a risk of coming back locally and need radiotherapy. Carolyn asks, do you know if there's any new treatment or trials for triple negative after treatment protocol? I couldn't participate in the trial as I didn't have the marker needed for the trial. I'm not sure what trial that is, Carolyn. So certainly with triple negative, there is a new drug in the metastatic setting. In the early breast cancer setting, there are a few trials looking at some of these drugs that have been shown to work in the metastatic. So I think with triple negative cancer, what's new at the moment is immunotherapy. There's a few studies looking at giving immunotherapy in the neoadjuvant setting, and some of them have shown positive results. Certainly not enough evidence yet for these to be standard. After the surgery, we use the capecitabine chemotherapy that I spoke about. A study just recently showed for women with breast cancer mutations, so BRCA1 and BRCA2 mutations, there is a benefit for those women in having a drug called a PARP inhibitor. After their surgery for 12 months, it reduces the risk of recurrence. So that might be a drug that becomes available in Australia soon for these women. But really the main thing that we're doing in triple negative now that's new is immunotherapy, but it's all still very much in trials. Nothing's really standard yet because we just don't know who the main people are that get a benefit. I think I've just reached my time limit and it looks like the questions have stopped. So I might actually leave it there. Thank you all for joining the session. It was really enjoyable to give it. And I will be doing another talk on another topic a little bit later on. And I hope you enjoy the rest of the sessions that you attend. Wishing you all a good evening.
My name is Navina Nekkalapudi, and I'm a breast cancer survivor. I was diagnosed with breast cancer when I was 39. It was a bolt out of the blue. I had no family history, no obvious risk factors, and it was a big shock to the system.
My name's Fiona. I'm 53 years old and I was diagnosed with metastatic breast cancer 6 years ago. I was diagnosed metastatic from the start, no family history of breast cancer, just out of the blue, and I'm trying as hard as I can to live well with breast cancer.
When you're first diagnosed with breast cancer and you go and see the first health practitioner and then sitting there telling you, oh, you got triple negative breast cancer and, we're going to do a lumpectomy and an axillary clearance and this and that, you're time constrained and you can't think of all the questions that you have right at that moment. And you go away and you go, damn, I never asked that question. My journey is really helpful because it answers some of those questions that you can't remember to ask your health professional.
One of the big challenges for patients diagnosed with breast cancer is the amount of information that is out there and really being able to narrow down to information that is credible and reliable.
I love the fact that with the My Journey, I can take it anywhere with me and I can have access to it when I'm sitting in a doctor's waiting room and look something up quickly that I want to ask about. It gives me some personal stories from members and the experiences they've had, and that makes you feel not so alone. It also links through to some really good podcasts and recordings that you can explore a bit more.
When you undergo cancer treatment, you suffer from not only side effects during the treatment, but also long-term health issues. And so the tool's really handy because there's information in there, not only for when you're a patient, but also when you're a survivor.
The My Journal is available as an app. It's really easy to use, it's convenient, it's downloadable, it's easy to navigate.
I was really excited when I found the symptom tracker. It's great because you can put information in at any time. You can track what your doctor wants you to track, but also stuff that you're curious about or worried about. And it's a great way to show the information to your doctor because often you forget to take all your bits and pieces of paper because you have a brain fog. Your cognitive function's kind of impaired because you're having chemo. Plus you have all the stress of undergoing treatment and what cancer means. And I find the symptom tracker really useful because it's all there. And you always take your phone with you, so it's very handy.
My Journey really tailors the information that I'm able to access to my situation. So because I'm metastatic breast cancer, the information around clinical trials will be very relevant to my treatment and ongoing care. And I know that it's trustworthy and reliable.
My advice to people who've been recently diagnosed with cancer is to be kind to yourself, to take it easy, and to find credible sources of information.
Hello, I'm Magdalena Simonis, and I'm really grateful and thankful to be here and invited by Breast Cancer Network Australia to talk to you all about the management of breast cancer in the community and the role of the general practitioner. I'd like to just introduce a bit about what I do. I'm on the BCNA Strategy and Policy Advisory Group and have been for several years. And one of the things about being a GP and involved in breast cancer is that we're at the coalface and we deal with the questions that people have and give time for contemplation around all the complex things around who you are and what really matters to you outside of cancer. Because what we do know is that once you have a diagnosis of cancer, it's not really about the cancer itself, although it might seem that way. It's really about you and your needs. And that's the way a GP likes to focus on the care of the individual. So I work as a GP, I'm a researcher, I'm on the strategy and policy board with a team of others at Breast Cancer Network Australia. And one of the things that really means a lot to GPs and patients is the concept of shared care. And it's a big statement to say that it's not just about the diagnosis, it's about the care over a period of time and across the journey. Now, BCNA has been instrumental in emphasising the importance of the journey and understanding that it's really about different stages, and at different stages the needs are very different. Now, when we see doctors, the first thing we talk about is about, the schedule for follow-ups. It's all about visiting the doctor, the examinations every 3 to 6 months in the first 2 years, and then mammography and ultrasound and all the other tests that you need to have for the first 2 years. So it's really busy and it's all cancer-centred. And then after the 3 to 5 years, things start to sort of broaden in terms of the length of time between appointments. And then after the 5 years, we start to think about how we can transfer the care of you and of people with breast cancer to the GP and back to the community, back into a sort of a normalised life where it's really about you and your specific person and your needs and where you are in your life and the stage of your life. And the follow-up can be conducted by the GP and communicating across the way with the specialists such as the oncologists, the radiation oncologists, the surgeon, and all the allied health professionals that are involved in your team. Now, I'd like to take the opportunity at this point to ask you all who are here, how many of you have a shared care plan for your management that you have since the diagnosis was made? So we'll look at the poll after a couple of slides. So if we can open the poll, and then I'll move on to the next couple of slides, and then I'll share with you the results before we move to the next question. So it's a yes/no question. How many of you have a shared care plan around your management? Now, what does shared care really mean? Well, in the first 5 years, we talk about, the surgeons and the oncologists and the activities around managing the cancer and diagnosing it further and determining what's best for you in terms of your ongoing treatment. And then after the 5-year period, Cancer Australia have announced that it's actually a really good idea to transfer the care to the GP. And so because there's more access to a GP, it's easier to have appointments, and it gives the opportunity to look at the whole person and make that really person-centred as opposed to disease-centred. And that usually should occur around the 5-year mark. And shared care is to be delivered by your GP, and as person-centred, we consider your genetics, the family members and how they've reacted, because a lot of time, your family members react with a lot of fear. And it's about being really responsive to your individual needs. Everyone is different. The age at which you're diagnosed, the stage of the disease, the stage of your career and how that impacts that. And some people really don't want to tell too many people in their community about this. Some like to keep it a big secret. And GPs are able to adapt this to make sure that your management still suits you, but without the emphasis on, talking to a team of other people all the time. Women should be supported to co-design the management plan. So, this is about you having your input, having a look at how the plan looks for your future and what you want to be doing, and looking at all the different aspects of your life too, and having the opportunity with a GP to talk about this. So there are lots of other service providers involved in your care, as we've talked about in the initial stages. You've got your surgeon, oncologist, your physiotherapist. Psychologists can come into the equation also very often for support, lymphedema therapist, and then there's community support. And GPs help you with the lifestyle choices and plans to promote living well, because this is really what it's about, and to prevent further disease. So it's not just about cancer, it's about screening for other health issues like your cervical screening tests, skin checks, and depending on your age, your diabetes screens and blood pressure, and fecal occult bloods also for bowel cancer, and looking at the genetic background and the family history for other things that we might need to be aware of and observing and screening for. And then also talking specifically about your psychological and even spiritual well-being. And GPs have the capacity to communicate with all health professionals and with allied health providers. And we also have tools within our scope to access these under Medicare benefit schemes. So what I'd like to ask you now, if we can close the first poll and share the responses to that, please. If we can share the first poll, and then we'll ask the next question, which is about how many of you have actually been involved in co-designing your shared care plan. How many have been involved in making those decisions? So could we have the answers to the first poll? So I'll have a little look at this. So we have around 23% who've said that they do have a care plan, a shared care plan, and around 76% who have not got a shared care plan. So that's quite interesting, because this is one of the areas that's going to make a really big difference to wellbeing and moving forward. Now, how many of you were involved in setting up your shared care plan? So far, we have about 13% that have been involved in establishing a co-designed care plan with their doctor, and around 81% have not. I think that's really telling, and I think that this is something that needs to be advocated for and talked about a lot more with the GPs, and something that you can take away from here too, because what this is about is really about co-designing your plan and helping you have control. One of the things that cancer does is it takes away your sense of control. A lot of the fear, a lot of the discontent, and a lot of the disruption is about how did this happen, and why did this happen, and why did it happen to me, even when there is a genetic predisposition. And I think that it's really important to support the whole person in this co-design, person-centred care. Now, there are two main ways that GPs can do this. One of them is through the Chronic Disease Management Plan. You may or may not know this exists, but GPs can access allied health professional services, 5 of them, over a 12-month period. It doesn't sound like a lot, and it's not a lot. And really, we do need to advocate for more allied health services to be provided by the Medicare benefit scheme for that, well, after the 5-year period, not just in the acute period where you do have access to these services. So it is a shared care, a GP chronic disease management plan, which allows you to plan your care over the 12 months and then also access some allied health services. Now, GPs can also access these services sometimes through the primary healthcare networks. So depending on where you live, and in certainly a little more difficult if you're in rural or remote regions, in major metropolitan areas, there are some services through community health centres that provide allied health services at a much reduced cost. And then, of course, there's the mental health care plan for mental health services and support through this journey over time. So many things change. It's not just about your disease. It's not just about your work. It's not just about the cancer and the fear. It's also about its impact on your life and your work and your career plans, and how this has disrupted things for you, and how you can navigate all of that. And it's about helping women live well and helping plan some exercise programs, bone strengthening exercises, yoga, ongoing health checks, and then the specific needs of young women with breast cancer who are planning for children and have had those plans disrupted, and how we can support women through that. So the whole of person care, it's not just about cancer. It's, the cancer's gone, but the fear remains. And there's a heck of a lot of concern around altered body image, understandably, and whether or not there should be breast reconstruction, and if so, at which stage, and early menopause. What does this mean for young women? And what does this mean for managing symptoms when you are not a candidate for menopause hormone therapy, and yet you're disrupted, your sleep is disrupted, and you can't have a night's decent rest, and yet you want to go to work and you want to function, and you want to function well throughout the day. And the obvious ones in your relationship, your sex, how comfortable it is, and whether or not being intimate is something that's on the agenda for you still during all this change, when a lot of the issue around body image can affect that intimacy and that confidence that women have and people have when they're diagnosed with cancer. And libido is very much affected. It's as much a mind issue as it is a body issue. And talking through this with a GP and providing support for these changes that are a stage can provide a support that isn't necessarily available through other avenues. And having the relationship with the GP is something that's really significant to navigate all of these complex and personal, intimate questions. Then there's lymphedema, and John Boyage, the lymphedema specialist and breast cancer specialist from Westmead Hospital, talks a lot about this and talks about scheme. He talks about how looking after the skin, compression, the importance of exercise, and the importance of massage. So this already touches on so many of those allied health aspects. And then there's bone health and how you support your bones, and heart health and weight changes and health screens and cancer screening. All of this fits into the shared care plan, and this is what you need to be maintaining over the course of time with your GP. Navigating relationships with your partners, friends, family dynamics, and then your expectations versus their understanding of the disease and how it's affected you. So oftentimes the members of the family will come and see the GP and say, look, things are really different. I need support, understanding what their needs are and how I can be more understanding and how I can better understand how this can how I can be of some help. And then there's work, during treatment, after treatment. Who do you tell at work, and do you feel comfortable telling people at work? And how does a doctor help you navigate those breaks in your work life without making it a public announcement? And who do you choose to tell within the work environment so that everybody doesn't know, when you really don't want to have them know that this is why you're unavailable or inaccessible? And then there's the cost. So there are so many requirements going down the path and along the journey, and not everyone can afford the access to allied health services, which make a difference to the quality of life and your well-being and yes, massage should be funded, and exercise physiologists should be funded, and a dietitian who helps you choose your food better should also be funded. How do we manage this? And a GP can help you construct some of these plans. And then self-care, and really, it's a really big topic, because you think, what does self-care really mean? And it takes on a whole other meaning when you've had a cancer diagnosis and it's in the background. So, well, it sort of means a lot. It means a lot for different women and for different people at different stages of their diagnosis and stage of disease. So a 29 to 39-year-old woman versus a 40 to 50-year-old woman versus a 50-plus-year-old woman. The conversations around this are going to be really different. And then, diagnosis of breast cancer in younger women is very complicated, because you need to talk also around the issues of fertility and how you manage that, and whether or not they have a partner. So I find that this is a really important opportunity to talk to my patients around preserving eggs, even if they're not in a relationship, in case down the track they choose to have a child, and giving women back that control where they feel they've lost control or even lost an opportunity. And these are also conversations that we need to have further down the track with women around menopause and how they're feeling on their medication and how we manage the symptoms, and finding other ways of managing things without bringing in the hormone therapy that we'd otherwise use in hormone replacement therapy for menopausal women. And so the big emphasis here with the shared care plan is helping you focus on self-care. That's really what it's all about. And it encompasses so many different things. It encompasses your lifestyle and wellness of mind, body and spirit, and your diet, what you ingest and how you ingest that and when and what. So it's really about you, and the aspects of it that need to be really discussed and focused on and encouraged through your shared care plan are about your mental health, laughter, your love relationships, touching on all of that. The importance of aerobic exercise, which is really important in terms of helping your energy, your muscle strength, and also your bone strength. Yoga, Pilates, the benefit of dance and Tai Chi, and things that can invigorate and lift up your spirit and your mood. There's also, of course, meditation, some also for prayer, and connecting with nature. They are really important prescriptions that we should be encouraging to incorporate into your life, because it does shift the focus. It shouldn't be about just going back to work. It shouldn't be just about going back to the normal pre-cancer you. It should be about moving forward with the self-care and with you centered around being well. And that is a really important lesson that we all take. As doctors, we learn that from our patients, which is why we're forever grateful for what they teach us. And as patients, that is something to emphasise also in your life moving forward. And for women from CALD backgrounds, culturally and linguistically diverse backgrounds, and Indigenous and remote populations, there are challenges there. So using the GP's telehealth services and video consultations, and also for psychological services, is really important. Then there are mobile units for the allied health services, and nurse navigators who help you link to certain services in the outer communities and in rural communities are really important. And there are some online numbers that you can access that can help you access the services that you require. I think part of what BCNA has provided is the face of the person who has cancer and their needs. And BCNA is trying constantly to answer those questions and provide those services and advocate for that. And I think that it's a wonderful site to visit. We as GPs do recommend patients, women, access BCNA online. And there's the online tool now, which used to be in a book form and was sent to people upon diagnosis, and now it's an online tool, and it helps you access information that's current, that's accurate, that's evidence-based, and also in the middle of the night, you know, when you wake up thinking like, you know, this is really me, this is really what's happening to me now, and feeling helpless and scared. And it is a support to know that there's something reliable where you can put in your questions or look up your questions and find that there's a whole wealth of knowledge that's being shared there, and that having a cancer diagnosis does not mean that you cannot live well, and this is about living well and the journey. Then there are the online support networks, which some require and some benefit from, and peer support. And then there's also the support of family and friends. And I think that the GP shared care plan is something that we can update every year. There are team care arrangement reviews that can occur at 3 to 4 months every year throughout, every 3 months, 3 to 4 months throughout the year. And it provides an opportunity to check in. So it's not really just about the cancer, it's really about your wellbeing and your care. Now I'm going to look at some of the questions that we've got, and I'll share these with you. I live in a regional area, this is from Gay, and I can't find a family GP. What do I do? That's a really, really good question. I think where you need to start there is ask friends who they're accessing. There usually is a service for people living in remote areas. You can access a GP through word of mouth anywhere now through telehealth. So I think that if you contact BCNA, or even if you contact the Royal Australian College of General Practitioners and you let them know that this is one of your issues, you can access, they will be able to give you access to the GPs that are within your primary healthcare network. And there are 9 primary healthcare networks, and they will be able to support you in helping you find something within your region and pair you up with a GP. The other alternative is also to ask through your service provider, the hospital where you actually had the treatment, because they may well have access to GPs within the area that can support you, that they have on their database. So sometimes I receive requests from hospitals for shared care services from patients I've not met who are in a situation such as yours, who don't have a GP. So telehealth is a wonderful opportunity for this, to engage and start the relationship, and so is video conferencing through that. Another question, in shared care plan different from a GPMP? Good question. It's pretty much the same. The shared care plan that you get from the surgeon or the oncologist shifting to the GP is a discussion point. So that's not a GP, that's not a general practice management plan. But the general practice management plan is the shared care plan. And you can use that specifically, or you can create something independently of that. But the issue, the good thing with the GPMP is that it gives you access to the team care through the allied health services for 5 services over the year. And Gay asks, what is the ongoing training for GPs for breast cancer? I've seen GPs, when it's urgent, who have absolutely no idea because about breast cancer and treatment effects. That's a real issue. I think that's faced, I think so many professions are facing a similar quandary or issue, because what happens is some GPs decide to specialise in particular areas. So they might be particularly interested in things like musculoskeletal medicine. So they're really good at sports medicine. And then there are other GPs within a practice who will practice mainly in psychological therapies and mental health support. So you are correct. That sometimes you strike a GP who hasn't got that much knowledge of current information and up-to-date information. And the answer there would be to seek another opinion and to ask them for someone who does have that capacity, either within their practice or a friend. Sometimes it is word of mouth. But GPs are having a lot of training in this area. It is also selective. You can choose what you want to do your extra training in as you progress. So it is very much about, some GPs are generalists and some GPs seek to practice in a particular area of their interest mainly. Vicky asks, it would be good to know of the 22% in shared care, how many are in the phase out of acute care? That would enable a shared care model. Yeah, that's a really good question. That's a really good statement. I think that knowing how many are out of the acute phase is a really good idea to follow up on and assess, because the shared care doesn't need to happen forever. It's really for when you need it, but it provides a pivotal point for you to think really about your taking charge, taking control, and having your focus and the focus around your well-being as opposed to just and only cancer. Yeah. So I think that some of these questions are really, really fascinating. Yeah. So let me see. So I think I have to scroll through that to get through the next ones. And I think I have. So, sorry about this. Oh, overtime. So, well, I'd like to finish up here. So thank you very much for your time. And thank you, BCNA, again for having me and for providing this wonderful webinar tonight.
Thank you, Magda. I think you absolutely proved to us the very important aspect of breast cancer, that we absolutely have to find the right GP to help us navigate through this system. So we are now going into a Zoom breakout sessions. So you can see on the slide below all of the different sessions. If you go to the screen to where the blue arrow down button is, click down there and all of the different Zoom meetings will be provided to you. Click on those, go into your group, grab another cup of tea, and we'll be right back with some amazing breakout sessions where you'll be able to mix with each other and ask very important questions of the clinicians that we have. Well, welcome back. It sure has been an action-filled night. So we're moving into the final session for this evening. For those joining us for the first time, welcome. For those who've been with us all night long, thanks for sticking around. But tonight, I'm really thrilled that we have an international best speaker to join us now. The next speaker is Dr. Eric Weiner, who's the Director of Breast Oncology Center at the Dana-Farber Institute in Boston, USA. And Eric will help us to look not just at the treatments and how we've evolved, but help us to look forward on what is to come. So please welcome Dr. Eric Weiner.
Good morning, good afternoon, whatever time it is for you. I know as I'm recording this, it's the evening here in Boston, Massachusetts in the US, and it's the late morning in Australia. I really appreciate this invitation, and I was asked to talk about breast cancer, where we're going in the next 10 to 15 years, and I will do my best to give you some sense of that. So the topics I want to cover is briefly, I want to talk about the progress we've made over the past 2 decades. I want to talk about individualization of therapy. I want to talk about the improving effectiveness of treatments we have. I'm going to talk about therapeutic de-escalation, or who needs less, the possibility of curing metastatic disease. And finally, I'm going to end with just one slide and a few comments about partnerships between patients and providers. So, in my view, we have made fairly dramatic progress in the past 2 decades, and I'll contrast that to the decade before that. So the last 10 years of the last century, when in fact it felt like everything was stalled. And over the past 20 years, there has really been very substantial progress made in research related to breast cancer, and more importantly, in treatment that affects women and occasionally men with breast cancer. So we have seen the subclassification of breast cancers by both the estrogen receptor status and the HER2 status and genomic characteristics of the cancer. We have a recognition that one size doesn't fit all, certainly in terms of adjuvant therapy, but really in terms of all therapy. We've seen the identification of multiple new agents, chemotherapy agents, hormonal therapy agents, targeted therapy, and now most recently immunotherapy. At the same time, there have been improvements in surgery, improvements in radiation oncology as well. We've paid much more attention than we did in the past to treatment toxicity and to patient preferences. And I think it is fair to say that women with breast cancer in 2021 have a far better quality of life than women receiving similar treatments 2 decades before. And at the same time, there have been very substantial advances in the treatment of patients who have metastatic disease, who may ultimately lose their lives to breast cancer, but who are living longer and are living better. So first, in terms of the classification of breast cancer, there has been a lot of work done looking at the heterogeneity of breast cancer, meaning that one woman's breast cancer isn't the same as another woman's. That work has focused both on the genome, or changes in DNA, and what's called the transcriptome, or changes in RNA. And what we know is that breast cancers sort themselves out into at least 4 or 5 very important different subgroups, and that these subgroups have meaning in terms of how we treat them. Much of this is also aligned with whether the estrogen receptor is turned on or whether the tumor is estrogen receptor positive, and whether HER2 is amplified, which means there are too many copies of HER2 in the nucleus of the cell. And we've had many new agents that have been developed over the last 20 years that have really made a difference. On the left-hand portion of the slide are all the treatments that have been developed for HER2-positive breast cancer. Trastuzumab, commonly called Herceptin, pertuzumab, commonly called Perjeta, TDM1, commonly called Kadcyla, are all remarkable advances. And then we've had neratinib, and more recently tucatinib, and a drug that's called trastuzumab deruxtecan. These drugs all have an important impact on women who have HER2-positive breast cancer, and in most cases, they not only control the cancer better in women who have metastatic HER2-positive breast cancer, but they prolong survival. And in women with early-stage breast cancer, these drugs have clearly contributed to the higher cure rates. I've listed at the bottom subcutaneous versions of trastuzumab and pertuzumab, and I did that not because they're new drugs, they're just new ways of giving the drugs. And the possibility of giving subcutaneous drugs means that women in the future may not be tied to infusion units and may be able to take more of these drugs, even the drugs that aren't pills, at home. And then on the other side of the slide, the first three are what are called CDK4/6 inhibitors, which have revolutionized the treatment of hormone receptor positive breast cancer in that they have substantially improved the results with hormonal therapy alone. I call these drugs superchargers of hormonal therapy. Then there's a drug called Afinitor, another drug called alpelisib. Both of these have had somewhat of a less dramatic impact. Neither of them has been shown to extend the lives of women with metastatic breast cancer, but both are at times effective in controlling cancer. And then finally, we have the newest on the list, a drug called sacituzumab govitecan, which is specifically at the moment for triple-negative breast cancer and is a remarkably effective drug antibody conjugate, though it has side effects that are very similar to chemotherapy. And finally, we have the two immunotherapies that, at least in the United States, are approved for breast cancer, and those are atezolizumab and pembrolizumab. As you see the names of these drugs and hear me pronounce them, you must think that in order for a breast cancer drug to become approved, it must be totally unpronounceable. Sometimes we think that as well. And in truth, even the brand names of many of these drugs are almost impossible for us. Not only has there been progress in terms of medical therapy, there's been progress in surgery and radiation. There's been, over the past 20 years, the widespread adoption of conservative surgery and radiation for patients who are interested in breast conservation, and for a patient who is eligible to have breast conservation or a lumpectomy. There's really no reason for that woman not to pursue that approach. We know that survival outcomes are absolutely equivalent between lumpectomy, radiation, and mastectomy. There are far, far fewer axillary lymph node dissections performed in 2021 than was the case 15 and 20 years ago because of both the advent and then the further development of sentinel biopsy techniques. There have been improvements in reconstruction options for those women who have to have mastectomies. Reconstruction is better than it ever was. And finally, there are shorter and yet equally effective and better tolerated radiation approaches. The other major change over the past 2 decades has been the extent to which we can individualize therapy. As I mentioned before, one size does not fit all. That individualization is based on the extent of the cancer, on what I often call, when I'm talking to patients, the personality of cancer, which means the biologic features of the cancer, whether a cancer is fast growing or slower growing, whether it's HER2 positive or HER2 negative, estrogen receptor positive or estrogen receptor negative. We, of course, have to pay attention to the available therapies, to the competing risks that a patient may have. So, for example, a woman who has had 2 heart attacks in the past year and who's 65 years old may be treated somewhat differently than a woman who's 35 and has no medical problems. We have to worry about her other conditions. And finally, there's patient preferences. And patient preferences are really critical here, since ultimately patients are the ultimate decision maker. And particularly when we're talking about therapies that may have a small benefit, it's critical that patients play a role and play the major role in deciding whether getting that therapy is worthwhile in exchange for a certain amount of toxicities or side effects. So let's now talk about improving the effectiveness of therapy. And first, we'll focus on HER2-positive breast cancer. So this was a large study called Affinity, a randomized study that involved thousands of women and compared chemotherapy plus trastuzumab or Herceptin versus chemotherapy plus trastuzumab and the other antibody, pertuzumab. And what you can see here is that there's a very slight improvement, a 2% improvement for giving pertuzumab in addition to trastuzumab to these women, looking at them at 4 years after their diagnosis. But given the fact that pertuzumab had relatively few side effects, that 2% improvement may be worthwhile to many people. But importantly, there were some women in this study who got a much bigger benefit and some who got a much smaller benefit. And the key for us as researchers and clinicians is to identify the patients who get the most benefit from therapy. The other point I want to make from this slide is that looking at these women 4 years later, 90% of them are free of any recurrence of cancer. And even those who had a recurrence of cancer, many of them had a recurrence of cancer, for example, in the other breast or in the same breast, and could then go on and be cured. Now, as we look forward, and as we do better and better in women who have HER2-positive breast cancer, it no longer is practical to do studies where we're trying to prove that a treatment is 1% better than another treatment. So looking at a treatment that might be 94% effective instead of 93%. And this is where we're increasingly relying now and will even more so in the future on what is called neoadjuvant or preoperative therapy. So this is where instead of doing surgery first, we give treatment first. And what we've learned is that what happens in the breast is oftentimes very much predictive of what happens to the patient. And the major lesson here is that for women who have all the cancer go away in the breast, and this, for example, is using chemotherapy and antibody therapy in women with HER2-positive breast cancer. But what was found is that for women who had all the cancer go away in the breast, 93% of them were alive and free of any recurrence 5 or 6 years later. In contrast, shown on the red line are the women where the cancer didn't all go away, and you can see that the outcome is much worse. Now, this was shown not only in women who had HER2-positive and hormone receptor-negative breast cancer, but also in women who had HER2-positive and hormone receptor-positive breast cancer, although there's a little difference here. And that difference is that women who had all the cancer go away still did exceptionally well. 96% of them had no evidence of any kind of recurrence. 97% had no evidence of a distant recurrence. But what's different here, and this is true of hormone receptor-positive breast cancer in general, is that even if the cancer didn't all go away, those women did not do so very poorly at all. They did better if the cancer went away, but again, not so badly if it didn't. And this has now been seen in other studies where what's called PCR, which stands for pathologic complete response, indicating that at the time of surgery, there's no cancer in the breast, is a predictor of outcome for individual patients. Now, what this means is that as we're trying to improve the effectiveness of therapy, this is true in HER2-positive breast cancer, it's also true in triple-negative breast cancer, there's the possibility that we can use neoadjuvant or preoperative therapy to individualize therapy for women and to ask questions about who needs additional therapy. So given the data that I just showed you, perhaps we can stop or de-intensify therapy in patients who achieve a pathologic complete response because we know that they're going to do very well. Conversely, we can use possibly the failure to achieve a pathologic complete response as a marker of benefit for subsequent therapy. So perhaps it's those women, not the entire patient population, but just the women who are not able to have all the cancer go away in the breast with the initial regimen, who then need to be treated with additional therapy. And this may allow us to further individualize and to use new therapies in those women who need it the most. I'm going to show you two clinical trials that have tried to do just this, one that's completed and one that's ongoing. This is what is called the Daphne trial. It is a trial that we did at Dana-Farber in approximately 100 women with stage 2 and 3 breast cancer. We treated them all with a simple regimen of trastuzumab, pertuzumab, and just one chemotherapy drug, the drug paclitaxel or Taxol. They received it for 12 weeks. Among the 50% of women whose cancer all went away at the time of surgery, we then gave those women no further chemotherapy, and we're following them to see if they do well, and we expect that they're going to do exceptionally well. In contrast, women who had cancer left at the time of surgery received additional therapy, and this, in our mind, was a way of helping to individualize therapy. And the definitive trial looking at this in the United States is what's called the COMPASS trial. The COMPASS trial is similar to the trial I just showed you. It takes women who have stage 2 or 3 HER2-positive breast cancer. All women receive 12 weeks of THP, Taxol, Herceptin, and pertuzumab. Those women who have a pathologic complete response go on and receive antibodies for the completion of a year, but no further chemotherapy. In contrast, those women who have residual cancer receive additional chemotherapy. They also receive the drug TDM1, which is antibody drug conjugate, which has been shown to be useful here. And they are randomized to receive either the TDM1 alone or TDM1 plus a new anti-HER2 drug called tucatinib. And again, the importance of this is that we're isolating the patients who are at greatest risk for recurrence, and in those patients, asking whether additional therapy will be helpful in preventing recurrences. So, in terms of improving effectiveness, what about another situation? What about triple-negative breast cancer? And what about the use of immunotherapy? As I'm sure all of you know, immunotherapy has been hugely beneficial in men and women with melanoma and renal cell carcinoma and lung cancer. And in breast cancer, the benefits from immunotherapy have been harder to discern, although over the past 2 years, we've had trials that have shown that in women with a certain subtype of metastatic triple-negative breast cancer, that immunotherapy can work. But can we use immunotherapy earlier in the disease, that is in women who have stage 1, stage 2, stage 3 breast cancer, to help prevent recurrences? The problem, of course, is that there are a lot of side effects from immunotherapy, which include thyroid problems and adrenal problems, specifically the adrenal glands not working, as well as potentially, though rarely, inflammation of the lungs, colon, heart, and other organs. And are these side effects worth the benefits? Well, this is really, in many ways, hot off the presses. The truth is the presses have not quite printed yet. And the final results from this study are going to be presented in 1 or 2 weeks in a virtual session from the European Society of Medical Oncology. This was a study called Keynote 522. It was in patients who had largely stage 2 and 3 triple negative breast cancer. All of the women received a complicated chemotherapy regimen with 4 different drugs. Half of them received a placebo. Half of them received the immunotherapy drug pembrolizumab. Pembrolizumab was then continued after the surgery in half of the women, and in the other half, they received just a placebo. And what was seen was that there was a higher pathologic complete response rate in women who received immunotherapy, shown in green compared to maroon, and that improvement was particularly seen in women who had node-positive breast cancer on the right-hand portion of the slide, where there was a 20% increase in the women who had a pathologic complete response. But what was most important, and I'm showing you data, and I said that there wouldn't be data for another week or two. These are the older data that were not quite statistically significant, and so the analysis that's coming are the final data. But here in this older analysis, there was about a 6% improvement in the women who were cancer-free. And what we're anticipating is that there'll be a relatively similar improvement when it's presented next week, but when it's presented, this will be with a statistically significant result, meaning that it's not arising by chance alone and that it is real. Now, the question, of course, is will this improvement in recurrences lead to a significant improvement in overall survival? We certainly hope that that will be the case. And then the bigger question is this degree of improvement, is a 6% improvement enough to justify some of the side effects that we talked about a few minutes ago? And this is going to be one of the big challenges for both doctors and patients, particularly for the patients who are facing this decision. How will we weigh the risks and benefits? Well, it's always challenging. And I'm going to move on, though, and talk about another situation. So when I think about making progress in breast cancer, there are really 3 big areas we have to work on. The first, of course, is the kinds of studies that I was just showing you, where we're escalating or adjusting therapy to try to improve the percentage of women who remain cancer-free. The second is to provide access to care to the large number of patients around the world who receive suboptimal care. And the final and very, very important topic that I now want to focus on is the need to minimize therapy in those patients who are likely to be cured who don't need more than somewhat minimal therapy. So this is a topic that's often called therapeutic de-escalation, where we're backing off on therapy. And some of you may hear this and you may say that sounds frightening. And of course, the truth is we don't want to compromise how well people are doing. But at the same time, we don't want to overtreat. Therapeutic de-escalation isn't confined to medical oncology. In surgery, the avoidance of lymph node dissections is an example of therapeutic de-escalation. In radiation oncology, giving 3.5 weeks of radiation instead of 6 weeks of radiation, which is now successfully the common practice, is also therapeutic de-escalation. In terms of de-escalation of systemic or medical therapy, there are a number of issues to consider. First, it's easiest to start this approach in risk patients, or perhaps in those who have many other medical problems where we want to minimize treatment. When we think about de-escalation, it can involve decreasing chemotherapy, decreasing biologic therapy like Herceptin, or shortening the duration of therapy. I think for most patients and for most doctors, decreasing or eliminating chemotherapy is top priority. Ultimately, de-escalation should be guided and thought through carefully sometimes by the results of preoperative therapy. So for example, in the studies I showed you where we were considering de-escalation in patients who had a complete response of their tumor. De-escalation can also be guided by biomarkers, by imaging, and again, sometimes we can think about it just in patients who have very early stage breast cancer. So if we go back and we look at the first study done with trastuzumab in patients with stage 2 and 3 breast cancer, we saw that patients who received trastuzumab in combination with both adriamycin and Cytoxan and Taxol had a better outcome. Now, when this study was done, there were very few patients included who had node-negative breast cancer, and even fewer, if not almost no patients who had very small tumors. And we know that patients who have stage 1 breast cancer and don't receive any kind of medical therapy have a generally favorable prognosis, particularly if the tumor is what's called a T1A or T1B tumor, which means that it's less than 1 centimeter. So with all of this in mind, one of the things that our group did, and this is now about 10 years ago, is we asked the question whether if you're a woman who has a small node-negative breast cancer, whether we could give you trastuzumab and back way off on the chemotherapy, giving you only 12 weeks of Taxol and trastuzumab. We didn't randomize patients. We treated a total of 410 patients this way, and we reasoned that if patients did exceptionally well, this would prove that other kinds of more aggressive regimens weren't necessary. And that is, in fact, just what we found. And through 8 years of follow-up, we saw these really exquisite results. You can see that that line barely dips below 1, which means that 100% of patients are free of a recurrence. And then when we look at the 7-year recurrence-free interval, and recurrence-free interval includes invasive local and regional recurrence, distant recurrence, and death from breast cancer, out of 410 patients, we had 9 patients who had that happen. And from this, we had a take-home message. The study didn't prove that this was better than no treatment. In order to prove that, you would have to compare no treatment with this regimen. On the other hand, at the time when we did this study, and today as well, most doctors and most patients feel that some treatment is important. And given the very small number of recurrences, if one's planning to give chemotherapy, it's hard to imagine that any regimen could be better than this simple regimen. And this study, which involved only 410 patients, has led to the widespread adoption of this regimen for stage 1 breast cancer really around the world, and I feel quite certain that it's used quite regularly for these patients in Australia. Another study that focused on de-escalation was the TAILOR-X study, which focused on women with hormone receptor positive breast cancer. There were over 10,000 women registered on this study. All of these women had estrogen receptor positive and node-negative breast cancer, and all had a recurrence score, or Oncotype DX, performed. And as I think many of you know, Oncotype DX is a 21-gene test that helps us determine a woman's prognosis and her sensitivity to chemotherapy. If the score was ultra low, less than 11, women received hormonal therapy alone, and if it was over 25, a woman was instructed by her doctor or advised by her doctor to receive hormonal therapy and chemotherapy. That was the plan in the study. But if women had scores of between 11 and 25, a place where we had questions about the value of chemotherapy, that woman was randomized to hormonal therapy or hormonal therapy plus chemotherapy. Among the women who had scores less than 11, all of whom received hormonal therapy alone, what you can see is that one couldn't have done better than with hormonal therapy alone. At 5 years, the distant relapse-free survival was over 99%. The overall survival was 98%, Invasive disease-free survival was a little lower at just under 94%, which reflects the fact that some of these women developed a second primary cancer, but we don't give chemotherapy to prevent second primary cancers. So in my mind, this demonstrates that in these women, hormonal therapy is clearly the standard. And in women with scores of between 11 and 25, what the study showed is that overall, there seemed to be no benefit for chemotherapy. So in this very large group of women, we demonstrated that chemotherapy, which had been the norm for many years, was simply not necessary. Now, I want to move on to one more topic before wrapping up and saying a few words about patient-provider relationships. And I want to ask the question, can we possibly cure metastatic disease? We know that for years we have said that metastatic disease is something that is incurable, and that although women who have metastatic breast cancer can live with it at times for many, many years, at times far longer than a decade, although that's by no means true of all women, or even the majority of women, it's not something that we can cure. But perhaps there are some patients who are cured with current therapy. We all have an anecdote or two from our own practices. Can we identify these patients, and can we attempt to cure more? So 30 years ago, this question was asked in the day when people were doing what was called bone marrow transplantation or high-dose chemotherapy with stem cell support. And in a randomized clinical trial, standard chemotherapy was compared to this very intensive treatment program that resulted in the death of up to 5 to 7% of patients who received the treatment. And what that study showed is that high-dose chemotherapy was not any better. But interestingly, in both arms of the trial, there were a very small number of women who remained free of cancer progression up to 90 to 100 months out from therapy, suggesting that there really was a very small number of patients who perhaps were cured of their disease. I think the major lesson from that study is that eradication of metastatic breast cancer is by no means a simple task. We can't just jack up the dose of chemotherapy. Intensifying chemotherapy by itself is inadequate. But on the other hand, as we develop more effective therapies, and in particular, highly targeted therapies, maybe the situation is different. So in the Cleopatra study, again, a study in HER2-positive breast cancer, and part of the reason I keep coming back to HER2-positive breast cancer is because this is the one subset of breast cancer where we have made more progress than in any other subset over the course of the past 20 years. But what was seen in this study is that among patients who received 2 antibodies plus chemotherapy, shown on the top line, that in fact, 37% of those patients at at 96 months were free of cancer progression. And this begins to suggest that even with this fairly standard regimen, maybe there are a small number of people who, if not cured, are living so long with it that one begins to wonder whether they're ever going to experience a recurrence of their cancer. So can we cure metastatic disease? I would actually argue that maybe this is already occurring and that we can take advantage of what we've learned, perhaps to increase the number of women who we might be able to cure in some settings. I think this is something that has to be restricted to clinical trials. We shouldn't have doctors out there, wherever, whether it's in Australia or the US or Europe or anywhere, who tell a patient that they're going to cure her metastatic disease and start making up all sorts of different treatment regimens. But I predict that clinical trials will begin to tackle this problem. Largely, it will be in patients who have newly diagnosed metastatic breast cancer, meaning they've never been exposed to prior therapy. And I predict that it will first be in HER2-positive breast cancer, but then it'll move to other types. And eventually, it'll move beyond just the patients who are newly diagnosed. And I would argue that the fact that I'm even raising this question, and particularly that raising this question with a large group of patients, suggests that we're making real progress. And I think that this is something that we should all be hopeful about. And so finally, patient-provider partnerships. So I've called this P3, and I think we used to call this doctor-patient relationships. And I'd actually argue that the world has really changed over the last 20 years or so. Doctors and patients, more than ever before, have become true partners. Patients, whether it's because of the internet or whether it's because of other forces, are more knowledgeable than ever before. When I see a patient, she, and occasionally he, has more information than they ever did and often know virtually as much about HER2-positive breast cancer or ER-positive breast cancer as I do. Doctors, I believe, in the current generation, at least in the US, but I think in Australia as well, are much more open to input from patients and families than they used to be. I think that's a result of changes that have occurred in medical practice, changes that have occurred in society as well. And I think everyone recognizes that it takes a team, a village, what have you, but it's not just about a doctor hero or a doctor non-hero and a patient. It's about the doctor and the patient and the family and the nurses and the social workers and everyone working together. In my mind, shared decision-making is the norm. Does that mean that every patient comes in and tells me that she wants to make her own decision? By no means. And I find that most patients are very interested in hearing what I think. But my job as a doctor isn't to tell somebody what to do most of the time, but to describe the options, to learn something about the patient sitting in front of me, and to try to match what in my mind is the best option for that patient, based not only on the characteristics of her breast cancer and on her other illnesses, but also on her own preferences. I think that patients have a right and deserve to have doctors and nurses who work with them closely on medical decisions and who really listen to them. And I will share with you that as a provider, by the way, I hate the term provider, but since I totally embrace working with nurses and physician assistants and others, I can no longer just focus on doctor. Somehow we should be something other than a provider. But for the provider, including me, caring for patients with breast cancer is a real gift. And if you open yourself up to that gift and to having relationships with someone, being a cancer doctor, and specifically for me being a breast cancer doctor, is incredibly meaningful and something that I feel very lucky to have had the chance to do for the past 3 decades and hopefully another one to come. So with that, I'm going to end. I'm really sorry that I'm not there with you, because if I were there with you, I could answer questions and engage in a conversation. That just wasn't going to be possible given the time differences in schedules. I enjoyed putting this together. I hope it was useful for you. I hope you have a great conference. And the last trip I made before COVID was to Melbourne. And I'm really looking forward to coming back to Australia again sometime soon once things relax a little further. Thank you very much.
Welcome back, everyone, to the Q&A section of this final session of tonight's Treatments for Breast Cancer Options and Considerations. Thank you for so many of you who have stayed with us, and welcome to those people who might be tuning in for the very first time. I'm now here with Belinda Kiley and Michelle to talk really about some key questions that have come from you through this section. And Michelle, I might start with you. You know, Eric really talked about that personalised care and what's kind of coming in the future. There's some real ethical challenges, I think, that clinicians face when new drugs and new treatment options are coming forward. They're not covered by the government. How do you kind of discuss those with patients to make sure that they really understand all the different options?
Great question, and absolutely one of the most challenging discussions I'll have with my patients. I think you have to be very gentle in the way you approach the discussion, and certainly, make it clear to the patient that there's lots of other good options available, but that there is this new agent, but there would be substantial cost associated with that, and you don't want them to be putting themselves in a circumstance where, they're having to, save money other ways.
Or tip into their superannuation, which many people are seeming to do these days.
Which some patients do want to do, but, you just have to make sure that the absolute benefit is going to be there for that patient. And the problem is you take a chance with any treatment that it may not be effective for that patient. And if they've really put themselves in financial compromise doing it, that is a tragedy. So I think a lot of patients are looking at people around them perhaps to help support them, GoFundMe pages, other things like that. But I think I always say to my patients, you just have to be completely honest with me about what's within your means and what's not.
Belinda, how do you, you're working in the public setting, how do you deal with these new and emerging drugs that are coming forward, which are really, I think Eric kind of talks about in a number of his speeches that all new drugs start at $150,000 for an individual patient these days. So what's your kind of approach to this?
Oh, it's really difficult. So I have the same concerns. I think that it's important. I feel like I need to let people know. So I would hate to not tell someone and then they find out that I never told them about it. So I always bring it up, and I always say that there is this drug, and I'm very honest with the cost. And I think that then it's just trying to explain to people what the benefit may be, what the side effects would be, the fact that it is ridiculously expensive, and most people would not be paying for this drug. And I guess, like Michelle was saying, there are a lot of other good drugs at the moment still available. And then I just try and do everything I can to get the drug made available for patients. So that's when I contact UKP and I try and get help to try and approach the government to get these things funded. But it's an awful situation. And I think when there's a drug that's very effective and I know it would help a patient and I know that they can't afford it, then I find that really difficult. And I'll often go home at night worrying about the fact that I've got this patient that I can't give a certain treatment to. So, yeah, it's not a good situation.
And it is certainly a very big part of BCNA's role in the voice aspect of our work, to make sure that treatments are available to all Australians, and particularly as new and emerging, more targeted drugs come, it's becoming more and more complex because of the way our system is formed. But I want to reassure everyone that we do our very best to make sure that we're advocating for the very best treatment for all Australians, no matter where you live and no matter how much money you or your family and friends have. The other interesting thing that I think Eric talked about, and I think health professionals who've heard me speak before, is this de-escalation approach. I think the word is very unhelpful for women. So Michelle, what are other ways we can talk about de-escalation?
I think we've talked a lot tonight about making sure we're giving the right treatment for that individual patient sitting in front of us. So that real concept of personalised oncology, I think, is a much more sophisticated way of describing it. I think a lot of patients worry when you're talking about de-escalating that they're getting less treatment than they need. And so I think, the model of giving the right treatment for the right patient and the right amount, in terms of side effects and long-term outcomes for the patient, I think is absolutely critical.
Belinda, one of the things that we spoke about in the early breast cancer presentation earlier tonight was about the 1 or 2%, and individuals needing to make really difficult decisions often about their treatment options. How, I know you did talk about it in the EBC, but I think it's really important to how you like to talk to people about what a drug or some kind of treatment might actually mean to their chance for recurrence or progression, so that people really understand what a 1 or 2% increase in risk means to them.
Yeah, I think that's really important, because I think it is very difficult, I think, for people to understand the differences between like relative risks and absolute risk reductions. And you can have a drug that is sort of being promoted as one that will reduce your risk of recurrence by 30%. But then if you explain to someone, well, look, your risk of recurrence is actually 10%. So if we reduce it by 30%, it's really going to be going from 10% to 7%. So trying to sort of explain what it actually means in the numbers. But even then, it's still quite difficult. And I think people, often people do struggle with what does that number really mean for me? So it is a hard thing to do. And I think, and it's also hard for us as the doctors to say what we think the patient would say was enough benefit to make it worthwhile. So I know that studies have looked at women who have received chemotherapy and asked them what sort of percentage improvement in your chances of survival would you want to make this treatment worthwhile? And many women, more than half, say 1%. So we know that a lot of women would actually like to have a treatment, even if the increase in their chances of survival was 1%. So I think it's always, I think we never can assume the size of a benefit that would be relevant to somebody. Because some people would say for 1%, I want it. And there's others that would say, well, actually, that's not enough to make me put up with all those side effects. So I think it's important, I guess, at the beginning, as well as explaining the percentage benefit, to be clear about the side effects. What are the side effects? How many of them could end up being more long-lasting or permanent, like peripheral neuropathy is one we've spoken about tonight. If it's a drug that's going to increase the risk of that, making sure people are aware of that up front. So, yeah, they're very complex conversations and not easy at all.
And I think I should really put in a plug here for why our network is so important, about women and men who've had treatment connecting and sharing their experiences with each other, so that people can make the very best, most informed decision. And of course, you're working with your clinician to understand your personal impact, but to have a network where people can actually ask those questions of each other while they're in that decision-making mode, it can be really powerful and really important. And, you know, we've always said that the My Journey information is about taking 150,000 people who've travelled the path before you and putting it into an app so we can help you make better decisions for yourself. So I think those personalised discussions that you have with your clinician are really important, but understanding what other people have, the path they've walked before, so you don't have that regret. Because so often we hear that regret, don't we, Michelle, where
Absolutely.
People go, I wish I hadn't had all that treatment.
Correct. And I think, for example, as Belinda has said, peripheral neuropathy is one of those side effects of treatment where when you're describing it to patients, they say, well, how bad could it be? Just a bit of numbness. Yeah, don't worry about it. But, you know, patients living with chronic severe peripheral neuropathy, and patients who obviously can report back to other patients, it can be a really debilitating symptom with a profound impact on your quality of life. So I think having those resources in place can really help in your decision making.
We just had a upfront about breast cancer, our podcast series, peripheral neuropathy. It's one of our most downloaded episodes. So we absolutely know that those side effects matter. And when we hear clinicians and patients talking together, people want to know what research is going into the side effects, because it's so debilitating in my life. So it's a really important discussion to have. And if people are going through treatment, we really encourage you to ask as many questions as possible. So Eric really did set the scene for how we have travelled with breast cancer. And I guess to finish tonight, Belinda, I'm going to throw to you first. I'm going to put her on the spot first. A question without notice. What are you most excited about for the future of treatment in breast cancer?
I think, like Eric was saying in his talk, the ability to give more personalised treatment, so really giving more, I'm hoping sort of increasing treatment to people at higher risk, but then being able to give less treatment. And I don't want to say de-escalating, but trying to give less chemotherapy is what I'm hoping. So I think there's a lot of research in hormone-positive cancer and HER2-positive cancer, and also even in triple-negative, trying to give other treatments instead of the chemotherapy and really work out who are the people that really need the chemotherapy, and then hopefully we can spare a lot of people the chemotherapy and the side effects. And like we were just, I mean, I'm thinking about that now because of that conversation about peripheral neuropathy. And I think there's a lot of people that I think would be wishing they could have had a way of avoiding chemotherapy. And I think we are getting better at doing that. And I think that's where the future is heading.
Michelle?
For me, one of the most exciting areas is in that giving preoperative chemotherapy, that neoadjuvant treatment, obviously allowing us to clarify, as Belinda has said, those patients who need more treatment and those who don't, and also being able to quantify for the patient their prognosis better. So some of the most joyous conversations you have is for a patient who's either achieved a complete response, so no cancer seen after their preoperative treatment or very little. We know that for many patients, their long-term outcome in that setting is amazing. And that's a really empowering thing for the patient to know. And for those that still have some disease left behind, knowing we need to give more treatment and doing clinical trials in that setting, I think that's, really becoming true personalised care for patients with early stage breast cancer and not over-treating everyone.
Mm. Well, I am going to wrap up tonight because it has been a very big night, but I just want to firstly thank all of our speakers, and we've had so many in all of the Zoom breakout sessions. So to Dr. Michelle White and, of course, Dr. Belinda Kiley, who's come from New South Wales online tonight, Associate Professor Magda Simonis, Yolan Antle, and Dr. Louise Kohlmeyer, and, of course, the beautiful Dr. Eric Weiner live with us from Boston. So a massive thank you to everyone. We've talked a lot tonight about the value of information, and I really would encourage people to go and look at the My Journey app now that you can download on your phone or your iPad or your desktop, and have a look at how we can help you curate the information so you are getting the very best and up-to-date day-by-day information about your breast cancer experience. It is a tool that is curated, as I say, for people with DCIS, with early breast cancer, with metastatic breast cancer, and we are updating the tool every day to make sure that it can provide a better experience for those people who are women and men that have been diagnosed with breast cancer. We have lots of upcoming events happening, very full calendar of both virtual and, fingers crossed, hoping that we can have some face-to-face. So I would really encourage you all to look at what those events are upcoming, and we are thrilled that John Boyage will host a Blokes and Breast Cancer Zoom virtual discussion on August 4. So that's a fantastic step for BCNA. Sexual health and wellbeing, something that we all know we need to pull the doona off and start talking much more openly about that. The cost of breast cancer, one of our most significant advocacy agenda items for BCNA in our voice section. And we do hope that, coinciding with the Australasian International Breast Congress in Brisbane, we will be able to have our first face-to-face conference in 2021. I want to finally acknowledge once again Cancer Australia, who has been supporting BCNA for a very long time, and in particular in helping us to reach the regional and rural women and men in our network. So I thank them for their ongoing support. But to end tonight, we're going to go back to our living legend up in Buderim. Please welcome Raylene Boyle, and another very big thank you for joining us tonight.
What an incredible night it's been. Thank you to the speakers, the facilitators, the BCNA staff. Thanks to all the participants, you people. You're the ones that are important. You're the people going through the journey at the moment. Thank you for your questions, your discussions in breakout rooms, and all of the information you've given us to fill gaps in the network of breast cancer. You're the people going through it. You're the one who can tell us where things are missing. And with that information, we can move forward and help fill those gaps and demand that they're filled and made better. BCNA is here for you, people affected by breast cancer. We don't exactly exist without each other. In fact, we don't exist at all without each other. Remember to sign up for access to the My Journey via website or app for the latest information and support relevant to your diagnosis, or call Member Support Helpline. Connect with people, connect with others going through the same thing that you are. And I hope tonight's been a fantastic success and full of information for you, and you can walk away and do your journey in a much better place.